Good morning. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're so pleased you're here for the release event for our October issue on violence and health. It takes a tremendous amount of effort to put a journal issue like this together. I do want to acknowledge the support of the financial support of a number of organizations. It's only possible with their support: the California Wellness Foundation, the Blue Shield of California Foundation, the Joyce Foundation, and the Annie E. Casey Foundation. This is a really important issue for us to have published. We often hear that violence is a public health issue, and it certainly is that. We're not a journal of public health, we're a journal of health policy. And so I think it's really important that we examine not just the public health aspects, but the health policy aspects of violence. As you can tell as you make your way through the issue, violence has tremendous implications on clinical practice. Clinicians need to understand it and respond to it in its many forms. It has tremendous implications for health systems, how they organize care, how they think about care, how they assure access to care. And in a related way, it of course has tremendous implications for communities, and clinicians and health systems and many others play a role in how communities respond to violence and seek to prevent it. And as one paper in particular gets into, there are tremendous implications for the research enterprise. This is not a topic that we are going to learn about just by muddling our way through. If we want to get better at preventing and responding to violence, we need to put the resources into research as well. So I think it's really important for a journal like Health Affairs to take a policy angle, a policy approach to this topic. And this is the first time we've attempted to do so. And I'm really proud of the collection of papers that we've been able to publish. When we produce a thematic issue, there are a few things that we do. One is, I believe, we have at the front of the issue a data graphic, tremendous collection of research findings, mostly, I think in this instance entirely, drawn from the journal. Gives you a picture that you can carry with you that shows the breadth of topics that we've addressed in the journal, and hopefully whets your appetite because you can't possibly fit all of the content into a data graphic. And we have a briefing like this. It's always hard to know exactly how to organize the content, but just to give you a little preview, we have a few overview papers that really describe the relationship between violence and health. A collection of papers that look at violence in the community, its implications, some of efforts to reduce violence in the community. A number of papers that look at mental health and suicide, both public opinion as well as efforts to try to reduce suicide rates, and then a number of papers that focus exclusively on firearms. Of course, these are all interrelated, but I believe it's valuable to look at them separately and then try to look at them together. So we hope you'll get a lot out of today's event. One of the things I will say is that when we move into areas that we haven't been as deep in, one of the great things is that we're putting all of this into the literature. So it's not just a matter, there have been some very interesting media stories just since the issue was released, but it's the lasting value of the myriad contributions that these papers make that we also are able to look forward to. And so we hope you'll join us not just today, but view this issue as an ongoing resource in your work. So the way we do this is that we have a series of panels. Each of our authors will have 7 minutes, and there's a timer and me with my hook to make sure that they don't go long. We have a lot to cover today. There'll be a little bit of time after the presentations. I will probably ask one or two clarifying questions. We'll try to get a few questions from you all as the day goes on. So without further ado, let me ask my first three panelists to join me up here so that we can begin, please. You'll be hearing from Brianna Mills, an injury epidemiologist and research scientist at the Harborview Injury Prevention and Research Center, David Grossman, senior investigator and pediatrician at Kaiser Permanente, Washington, and a senior medical director for the Washington Permanente Medical Group, and Tony Rosen, researcher in elder abuse and geriatric injury prevention at Weil Cornell Medical College, a practicing emergency physician at New York Presbyterian Hospital. So, well, I will hand it over to Brianna to kick us off. Yep, no rest, sorry. Keep this.
Thanks, everyone. I hope this is the least interesting presentation today because it is just an overview, and I'm really excited to hear what everyone else has to say. One of the things I think is most important to talk about is sort of the magnitude of the problem, especially when it comes to interpersonal violence. The simplest way that I can think of to express it is this. If you think that you are unaffected by violence, you're wrong. Even if you're not one of the millions of people that ends up in the hospital every year as the result of an interpersonal injury, even if you haven't lost a loved one to one of the 67,000 estimated violent deaths every year, you still live in a community that is responding and reacting to interpersonal violence. Looking at firearm violence alone, there's a 99% probability that someone in your social network will be shot in your lifetime. And there's an 84% probability that they will die of that injury. There's lots of different ways that we can look at interpersonal violence. When it comes to the effects, we sort of looked at some typical types of violence across the lifespan, from child physical and sexual abuse through bullying and other types of youth violence, which can encompass dating violence, school violence, gang violence, other interpersonal adult violence, and elder abuse. But we also wanted to look at different types of violence regarding sort of the intimacy of the relationship between the perpetrator and the victim. So violence in the community, sexual violence, and intimate partner violence. These are not tidy categories, although I present them that way just as a visual. These forms of violence are not isolated from each other. And they all have different types of effects on the human body, well beyond the initial injury that might require treatment. Specific forms of violence increase your risk of numerous chronic diseases, self-harm, substance abuse, mental health issues, risky behaviors, involvement in subsequent violence, social isolation, and economic hardship. A lot of this we know comes out of studies of adverse childhood experiences in relation to the effects of toxic chronic stress in children. The effects of violence are, as I keep saying, myriad, and extend far beyond the immediate physical trauma. There are chronic pain and sleep issues related to both intimate partner violence and elder abuse. There are effects of violence that are both severe and subtle, things like the shortened telomere length associated with being a victim of intimate partner violence or sexual violence, or things like the increased risk of self-harm and suicidality associated with many forms of interpersonal violence. These are both immediate and long-term effects. There are effects on the brain structure, on the function, and on neurotransmitters, some of which can manifest in risky behaviors and violence perpetration among victims of youth violence. There are also issues around permanent disability and social isolation following injury. There are changes in your neuroendocrine stress response, issues of chronic inflammation, and changes in the microbiome, which can have very unexpected physiologic effects, modified by your genetics, by your social and community context, and by your other adverse exposures, like poverty. Violence and its effects interact in ways that cause cumulative harm, both directly to the people who are targets of repeated violence and indirectly to their friends, family, and community. None of these effects or the mechanisms by which they operate are fully understood, and many are understudied. There we go. And where we go from here, in addition to the rest of today's presentations, is really an issue of prevention. From the earliest social determinants, risk factors, through the immediate acute care treatment of injuries and into long-term recovery and rehabilitation, sort of primary, secondary, and tertiary prevention. But more so, we need to acknowledge that violence is the source of the largest health disparity in the US, based on your race and ethnicity, on your gender and sexual identity, on whether you live in a rural or an urban area, and numerous other factors. And this needs to be acknowledged, and it needs to be understood, and it needs to be addressed. Violence, too late. All right, violence is not simple. The effects are not simple, and our response can't be simple. There we go.
Thank you.
I got a minute left.
Morning. Thanks for the opportunity here to talk with you and a little bit about the issue of violence and how it impacts the healthcare sector, and what a response from the healthcare sector might look like, at least provisionally. So by violence, I'm zeroing in on exactly where Brianna was, which is really, when I use the term violence, I'm talking about violence writ large, so both self-directed as well as interpersonal violence. And I believe that the health system has an opportunity to intervene in most types of violence, but not necessarily all, but certainly a dominant proportion of them. I think I also want to mention that before we talk about the impacts to hospitals and health systems, it is really important to acknowledge the toll on victims, survivors, families, as really the key area where that pain is really felt. But hospitals and health systems are a key stakeholder. Do you have? There it is, thank you. Hospitals and health systems are a key stakeholder to stem the loss of life and disability from violence, because healthcare providers not only see the victims of violence, and it isn't just people in emergency rooms, it's people throughout the healthcare system, but we also have access to future victims of violence. So to the extent that we can identify people and intervene, we have a potentially important role there. So our premise is that healthcare and health systems can play and should step up and have a more central role in reducing certain types of violent injury, not only in their systems, but also in their communities. So for starters, the CDC estimates that 2.3 million emergency department visits each year are associated with violent injury, and that those lead to an additional 376,000 hospitalizations each year. These lead to huge resource consumption, and some people might say this is as preventable injuries, these resources could have been used elsewhere. In a single year, about $8.7 billion in the United States is spent on direct medical costs covering the area of acute care, rehabilitative care, as well as chronic care over the long term. And a sizable portion of those people who receive that care actually end up dying. And many of the people who die never receive any medical care at all. Most suicide deaths actually occur in the field and are never never have an opportunity to receive any kind of care. Finally, I just want to mention in this slide that violence occurs disproportionately to the poor and also to the uninsured and underinsured. And we believe that in looking at the literature in this area, that it appears that Medicaid expansion probably has a positive impact on individuals who have suffered from violence and who are in that area. The uninsured and the underinsured have received greater coverage for comprehensive care as a result of the ACA. So then, the burden of violence is not just about the adding to patient volume and complexity, and it's also healthcare institutions themselves are relatively dangerous places to work compared to other workplaces and occupations. According to the Occupational Safety and Health Administration, the rate of occupational injury that leads to absenteeism about fourfold higher than all other occupations combined in the United States. That in the review of this area actually was a surprise to me on something that currently I did not appreciate. And healthcare workers are at risk across the spectrum of the worksite, starting from emergency medical services all the way through rehabilitative and behavioral health care. The other interesting thing we found was that emergency room physicians report a staggering high rate of assault in their workplace. In a recent poll that was done, half of them reported being a victim of an assault in the worksite. 50% of those have been assaulted within the last year, and many of those have been assaulted more than once. So worksite violence also has major consequences to victims. Just like Brianna described, those same consequences occur to healthcare workers in their efforts to try to recover from their injuries. And to the worksite and to the employer, it obviously has significant consequences with regard to employee turnover, morale, and productivity. And now the response. I've described the burden. We do believe that there are a number of potential roles health systems can play to prevent violent injuries and suicide and also mitigate their impacts. And in particular, there are a number of different opportunities here related to particularly secondary prevention, screening, and intervention. The U.S. Preventive Services Task Force recommends screening for depression among adolescents and adults, as well as screening for high-risk alcohol misuse. And in both of those circumstances, there's a high risk of both interpersonal as well as suicide, particularly suicide for depression, that we know of and that we know how to intervene. By identifying people who are actually actively suicidal and then identifying whether they have a gun in the home, provides great opportunity, and our ability to intervene may be helped by red flag laws that allow us to actually act on that information. Intimate partner violence screening is another potential opportunity for which there's probably substantial room for quality improvement, subsequently leading to, again, removal of firearms from the perpetrator who is in that position. And finally, the hospitals that treat trauma victims have initiated on their own a number of violence-based intervention programs through the identification of perpetrators, through the identification of victims, some of whom are perpetrators also, and then intervening with them using behavioral motivational techniques and other approaches to reduce the recidivism of that area. Finally, I just want to say worksite-based interventions and policies, there's far less information and evidence around what exactly works. But there has been some groundbreaking work, particularly in California, where the institution of the use of mandatory guidelines and proactively working with health systems to identify opportunities and policies within the worksite to prepare for violence can be potentially effective. And then community and hospitals also have obligations under the ACA to conduct community health needs assessments and thereby engage their community and help them work on community-based violence-based intervention programs. There's another opportunity. But I want to close by saying finally that we identified in most of these areas that there's really a paucity of research. It isn't just about research on guns and firearms that's capturing the media's attention. It's a research on violence in general. In violence intervention programs, there's many areas that could use substantial more funding and investment for us to have a truly evidence-based approach to this important area. Thank you.
Hi, I'm Tony Rosen. I'm an ER doc at Cornell in New York City. And on behalf of my colleagues, friends, and collaborators, Lena Macaroon from the Pittsburgh VA, Yates Conwell from the University of Rochester, and Emmy Betts from the University of Colorado, I also want to talk a little bit about an overview of violence, not necessarily primary research, which we're going to hear about later in the day, but focus on a specific population, older adults, the scope, the impact, challenges, and strategies for prevention of violence that involves older adults. So first, I really want to emphasize that violence is not a disease just of younger people. I think we think of quite correctly that violence is something that affects kids and that affects younger adults, but I want to emphasize that violence and the risk of involvement in violence continues into later life and commonly affects older adults. There are three major types of violent involvement for older adults. Violence directed towards older adults, which of course can include physical and sexual elder abuse and intimate partner violence. Self-directed violence, which includes of course suicide, but also non-fatal self-harm. And then violence perpetrated by older adults. While less common, this does occur, and of course intimate partner violence perpetration, but also, though there are other things, I want to focus a little bit on violence among folks that have dementing illness. When you have dementing illness, there can be a violent component to the cognitive impairment, and that can impact caregivers and others. So here is our first graph of the day. You can see here, to orient you briefly, this shows by age group risks, or rather death rates for homicide on the left and for suicide on the right. And the two things that I want you to see is, as you move into older age, while homicide rates go down, they do not vanish, and suicide rates go up. And so as you can see, there is real risk for older adults of violent death. In addition, if you look here, the estimated prevalence of violence towards older adults, self-directed violence, and violence perpetrated by older adults, the risk of non-fatal violence involvement is also much higher than most of us thought. And there is limited research, but the research that exists reminds us that this is something that is almost never recognized and almost always missed. In addition, there is real increased urgency for us to focus on this because of the anticipated growth of the geriatric population. Our baby boomers are aging, and healthcare is doing a better job of increasing the length of life. And so we expect that the amount of older adults in the United States is expected to double by 2050 to 83 million. And so these are the folks that we're going to be caring for in our emergency departments, in our hospitals, in our primary care clinics. Also, when you look at violence involvement among older adults, there are some key commonalities among the different types of violence. Of course, there are differences in risk factors, but there are some real commonalities in risk factors as well. These risk factors are the case for all types of violence involving older adults. I want to call your attention to two of them. The first is cognitive impairment. Cognitive impairment increases the risk dramatically of involvement in violence as a survivor and unfortunately also potentially as a perpetrator. Additionally, social isolation and low social support is another critical factor. We're going to hear about this more, I think, later in the day from Dr. Tung, but in older adults, it is a particularly critical thing for violence and frankly also for quality of life. In addition, the challenges in response are similar for different types of violence involvement in older adults. It is difficult to identify. Older adults are either unwilling or unable to report. And also, while this is true in all types of violence, it is particularly true in violence relating to older adults that when we think about intervening and we think about our approaches to prevention, we need to balance autonomy and self-determination for older adults with our desire to protect them from future injury. A couple critical topics that we focused on in our work, and I want to sort of highlight briefly today, are firearm access. We're going to hear about this from lots of other folks, including, for example, Dr. Goldstick later in the day. But in older adults, it turns out that 35% of adults aged greater than 60 own a gun. That's actually higher than younger populations, and another 14% live in a household with someone who does. And these are older adults, many of whom are either have dementing illness or may become demented over the course of the coming years. In addition, another group that we wanted to focus on is veterans. Our veterans are a population that we care deeply about, particularly, of course, because of their service, but they are also a rapidly growing population at particularly high risk for violence. Think of the issues related to gun ownership, related to mental health issues and PTSD that are so common among our veteran population. This is a population that is aging, and that is one that we really should be focused on. So where do we go from here? Well, a couple things that I wanted to highlight. The first is an integrated approach. Ultimately, if you think about integration, this is how we might approach intervention. Integration across the lifespan. Think about, can older adults be also served by interventions that already exist and serve children and younger adults? Across forms of violence, can we focus suicide prevention programs also on serving victims and survivors of elder abuse and intimate partner violence among older adults? And across disciplines, I think you'll hear over and over and over again today how important multidisciplinary responses are, and I think that that's particularly true for a population like older adults. And in conclusion, what are the key areas for action? Well, raising awareness and prioritizing funding. So thank you very much for the opportunity to present today and to let you guys know about this. Healthcare setting interventions. We think there's a central role for primary care, a central role for those of us that work in emergency departments. I know there are other folks that work in emergency departments that are going to be presenting today. And of course, emergency departments are a key area for prevention of all types of violence. And the VHA, the Veterans Health System, is our largest integrated health system. And as a result, they have a lot of resources. In addition, they have a key focus on suicide prevention and a lot of wonderful programs for older adults. Community-based interventions, AAA-focused programs, training for community gatekeepers, such as mail carriers, such as pharmacists and others within the community that can identify older adults at risk, and support programs for caregivers who may be themselves victimized. And lastly, and I think we're going to hear a lot about this later in the day, but firearm-specific interventions may be particularly relevant for older adults. Family firearm agreements, gun safes, policy changes gun ownership in dementia, I think have the opportunity to really impact risk in this area. So with that, thank you very much.
That was a terrific set of introductory papers. So since these are overviews, I'm going to ask sort of overview types of questions, not so much research questions. Let me start with something that stands out for me. On the one hand, we have this tremendous heterogeneity of types of violence, perpetrators, victims, and all of its shapes. And yet we group it all under the term violence. So when is it helpful for us to think of violence as a single phenomenon? And when is it helpful for us to disaggregate and say, here's a particular form of violence or population affected by violence? How do we, I know we need to do both, but how do we think about when to do which of those two? Who wants to start off? It's a broad question. David.
Yep. That's a really interesting question, Alan. And as someone who worked in the field of injury control for much of my career, we struggle with this issue, in the macro field of injury in general. So, for example, what do firefighters see themselves in common with automobile design engineers? In fact, they have a lot in common when it comes to thinking about prevention of injuries. The same is true for all of the segments of violence. And I do believe that we can't treat violence as a disease. I think, and Tony was alluding to that. We have to think about it more as a syndrome, and we need to be, from the purpose of trying to design interventions, and we need to be thinking about like cancer. No one thinks about treating cancer as cancer, and certainly NCI doesn't do that. And we all know that breaking the heterogeneous causes and interventions associated with cancer treatment are legion. And the same, I think, needs to be approached with regard to violence.
Any other reactions? I have more questions, but...
Yeah,
okay.
If it's working, I would agree, maybe I'm loud. I would agree with Dr. Grossman. From my perspective, I think where we are is recognizing that risk factors in many cases are similar. And so identifying a family in crisis and identifying opportunities for intervention are critical. However, I think from a research perspective, as we move forward, identifying individual types of violence and how we can most effectively intervene in the next phase will be very, very important.
I'm just going to, I think when you start talking about wanting to find specific treatments and specific relationships and specific mechanisms, you need to be talking about specific forms of violence in as detailed a way as you can, and then we aggregate up from there.
Yep.
Great. That's very helpful. We, of course, are all over health policy, and one area that you just hear about all the time is social determinants of health, the need to look upstream and think about the factors that cause people to have poor health. I go to lots of meetings where lots of people are talking about this. I hear lots of conversation about housing, some conversations about food, some about income. I cannot remember an event focused on social determinants of health where people talked about violence. So what's going on here? Am I going to the wrong meetings? Yes? Okay. Invite me to the right ones. So I guess my question is, and David, of course, your paper was focused on the health sector, but again, I'm interested in how all of you react to this. How do we assure that we broaden the lens as more people in the health sector are thinking, how do we move upstream to include this as part of what they're looking at?
Yeah, great questions. I think that this is an issue, and I alluded to this with regard to community health needs assessments. Health systems can go deep when it comes to investment in communities. Kaiser Permanente is one of the organizations that's actually investing considerably in social determinants of health, both in terms of food, housing, and other economic opportunities within communities. It's important to realize that what I laid out is primarily what I would call more reactive and secondary approaches that I think are closer and more easily implemented in the near term. But there's no question that what you're alluding to, which is that the primary determinants of violence in social inequities and injustice, are huge and absolutely need to be addressed. And I would argue health systems are a part of that solution as well.
Yeah, maybe I'm being too literal, but when I think of social determinants, I dislike thinking of them as something that happens upstream, because it's not as though you are born in a certain place and then something happens. It's not like a linear relationship. The things in your life that affect both the incidence of violence and then your ability to respond to it are ongoing. So I think sometimes people see it as something that has happened to you and then therefore can't be addressed, whereas no, these are things that are ongoing, and at the same time as you are responding to sort of the immediate needs that happen in the aftermath of violence, you can still be responding to the social and community context that is informing it.
I would add a few things. I think it's a really, really, really interesting question. And I think that for us, as folks that are thinking about violence, we need to think about violence as a continuum. I think that realistically, the violence that involves a firearm and a mortally injured patient is part of the violence that impacts social determinants of health, but so is the slap, so is the less life-threatening, but perhaps equally, or not equally, but certainly impactful on health type of violence. And so in some ways, we have a lot of our violence represents an unrecognized social determinant of health. And so from a research perspective, I think that we need to be thinking about how we can capture that more, particularly because what you'll hear from Dr. Tung and what I described as well is that folks that are socially isolated, which I think we hear a lot about as a social determinant of health, are much more likely to suffer from violence. And so violence ends up being, in some ways, part of the continuum of quality of life that we need to think more about. And so I think that violence really needs to be more a part of the conversation. And then I think our role as folks that are focused in violence is to remind others that violence isn't just, it certainly is, but isn't just firearm injuries, but also other types of violence and injury, even if there is no bruise, that can have a real impact on health.
I'm glad I asked that question. Brianna, thank you for redirecting thinking about social determinants is not just upstream. I think that's exactly right. And I very much resonate with the notion that when we talk about violence in public policy environments, we tend to talk about distinct events that have very visible manifestations. And part of what you're saying is there's a huge amount of violence that has no visible manifestation and yet is a huge health issue. And so we have to broaden, and in some respects that's an answer to the first question as well. My last question is no easier than the first two. In fact, it's probably harder. But Brianna, so line on up. Brianna, you introduced, and then it came up in all of the presentations, and it will throughout the rest of the morning, this issue of equity, and that you can't really take a serious look at this topic without understanding the disparities that underlie it. So couldn't agree more, but what comes next from that sentence? And I don't mean to just ask you, I just am just trying to make sure we
yeah, all right. I mean, I think the first step is you have to acknowledge it, and I think it has to be part of not just this conversations, but conversations going forward, that your likelihood of being involved in violence and your ability to recover to the best of your ability are informed by your identity. And that means that responses to violence have to take that into account, but it also just means that when we think about health disparity in general, violence has to be one of the areas in which this manifests.
Yeah, I would just add that the important thing to think about is that it adds violence to the list of things that unfortunately you're more likely, the folks that are more likely to have it are also simultaneously less likely to have access to the interventions that we have. And so given that, we really need to focus on changing the way that we think about interventions and having policy help drive the intervention approaches that we have. Recognizing that, as I said, interventions don't work if we can't access the folks that need them, and if we can't find the folks that need them. And so, unfortunately, I know it doesn't answer the question, but I think that hopefully it thinks about it in a way that points us in a good direction.
Yeah, I would just add to that. I think you're spot on, and I do believe that through access through healthcare, and if we really work to improve the integration of physical healthcare with mental health as well as social health, there is an opportunity here for finding that pathway that you're describing. We should be aggressively involved in helping people through that pathway and getting them into the right places. And if it has to be through our care system, then that's what it should be. But ultimately, success in this issue is going to involve really strong collaboration between not only the healthcare sector, but also mental health, obviously, which hopefully will be integrated, and criminal justice, which we haven't talked about at all. So highly successful community-based intervention programs. There's one, for example, in Ceasefire in Oakland that's been actually very successful. Really involves a close collaboration between healthcare and criminal justice. Really not for purposes going out and arresting people, but really to better understand and enhancing an understanding of the epidemiology in the community and the underlying community risk factors that can be addressed at a policy level.
We have time for a few questions from the audience. Please wait for a microphone. We do record this and want to make sure people can hear. And if you could just tell us who you are before you ask the question.
Hi, I'm Nancy Napolitano. I work for ECRI Institute, and I am an analyst and a consultant for their patient safety organization. So all of this is resonating with the work that we do. ECRI is also a research institute for health devices and things like that. One of the things that I love what everyone's saying is that our hospital systems need a paradigm switch. They really need to start looking at the stigma that's associated with violence and mental health, and that they don't always go together. And the ED, unfortunately, is the first line of defense for everyone, everything. I got a cut, my mother died, God forbid. But I just think that how do we get our policy, I don't know if it's a question, I guess it's a question. How do we get our policies to infiltrate the actual work that is being done at the health system level? Because a lot of the work we do, if the leadership doesn't believe that there's a workplace violence issue, then it doesn't exist, and the people don't get the support, and they don't get the second victim support when they acknowledge or when they are party to a violent situation. And, spitting, like you said, spitting, slapping, those are all parts of violence. So I don't know how we get from here to here.
So that's a really good question. And so it's one thing to point to solutions, it's another thing about how to actually execute. And execution is always, it's much easier to develop strategy than it is often to execute. And in this particular area, policy does play a really vitally important role. And I believe it involves leadership that comes from the healthcare providers themselves, who are integral parts of those institutions, that should be stepping up and demanding that level of interest and accountability. The investments in community, actually, as I indicated, have been reinforced by the ACA, at least for nonprofit hospitals. For-profit hospitals don't necessarily have to follow those policies. But, and I believe that since the ACA, the health systems have taken that process much more seriously. It's, I think, much more carefully governed. And I think having some really interesting results. And I do believe that health system leaders are really waking up and understanding the importance of their role in addressing this issue.
Yeah, I think it's a great question, and I think there are a lot of ways. I'll talk very briefly about a few that are going on now. For example, the American College of Surgeons, I and many others serve on a committee that has just released new best practice guidelines for trauma. Those are coming out in the next couple of weeks. And they're around improving trauma care for victims of child abuse, intimate partner violence, and elder abuse. And so again, that's a specialty physician society, or not just physician, medical practice society that's having an impact. Obviously, in hospital and primary care settings, agencies like the Joint Commission can have an impact. Also, however, there are policy changes. There is a recent state law in the state of New York, where I live, that was mandating that elder abuse training be offered to all healthcare providers in the state. And so there are opportunities at the policy level as well. But I do think that your question is really helpful in the sense that it focuses on two things. The first is paradigm shift. We want people in the health sector to recognize their really critical role. Socially isolated older adults or other violence survivors may present to a healthcare provider, and that may be the only time they present outside the home. And so it represents a really important opportunity. But also, we want to make sure that we get buy-in. And this is something that David was saying, is that there already is some buy-in at the level of our healthcare leaders, but I think that there are opportunities to improve that as well.
I'm just going to say, I think this is all true. We need policies, but we also need to make sure that the policies are being implemented, which means we need data, and we need a commitment to putting the numbers on the page, because there's a difference between knowing and hearing someone say violence happens in the ED and being able to say, we tracked it for a year and violence happens every day in the ED.
I would add to that, I think that's a really nice point in the sense that and I think that our colleagues in child abuse would focus on this a great deal, is to say that we recognize that these are problems and problems feel like they need solutions, but at the same time we want to be careful to not aggressively implement untested solutions and find out that we've created inadvertently new problems.
Okay, I think we're going to break here. This was a great kickoff, but we're going to have a lot more time to bring you into the additional papers that came up. Please join me in thanking our opening panelists. We have a crowded next panel, so we'll have a break after this, but those of you who are in the second panel, please come on up. As they're coming forward, I'll give you some brief introductions. Don't be shy. This next panel is on community violence, a broad term, but you'll see how much is covered in this panel. We're going to hear from Liz Tung, a researcher and practicing internist in the section of general internal medicine at the University of Chicago. Nichole Smith, a third-year medical student at the University of Chicago Pritzker School of Medicine. Dick Krugman, distinguished university professor at the Kemp Center for Prevention and Treatment of Child Abuse and Neglect at the University of Colorado School of Medicine, former dean, vice chancellor for health affairs, colleague of mine for many decades. Briana Woods-Jaeger, assistant professor in the Department of Behavioral Sciences and Health Education at Emory University, and Bernadette Hohl, assistant professor in the Department of Epidemiology at Rutgers University School of Public Health. Liz, we'll turn it over first to you.
All right. Good morning, everyone. I'm Elizabeth Tung. Thank you so much for being here this morning. I'm really honored to present some of the findings from our Chicago Violence, Neighborhoods, and Health study. I'm going to focus on the social isolation and loneliness findings from our study, and in just a few minutes, you'll be hearing from Nichole Smith on some of our other findings related to hypervigilance. So, as a practicing internist, I spent about half of my time in the primary care clinic. The isolating effects of violence began to catch my attention several years ago, around 2014 when I started my practice on the south side of Chicago. I had a number of patients telling me that they don't get out of the house much because they're afraid to go out, especially at night. I was talking to one woman in particular about maybe having family members take her out to run errands, and she told me that she was even afraid to have her son come visit her. And she said it was because he's a young black man with a bright future who made it out of the neighborhood. And she's terrified that being back on her block means he could be mistaken for somebody else and either get shot by a gang member or shot by police. So instead of asking him for help, she tells him she's doing just fine, even though she's really struggling with all of her health issues. So these stories in my clinic began to accumulate, and I started digging into this issue more and more. The late and great John Cacioppo was really a pioneer and some might say founding father of loneliness research. And he theorized that a hostile or violent social environment can erode the very foundation of social connectivity, which requires trust, security, and the feeling of being meaningfully connected. So I just want to do some quick definitions to get us all on the same page. Social isolation refers to the absence of social contacts or opportunities, and some objective measures of this can mean living alone, having few social contacts, or having infrequent social contacts, whereas loneliness refers to the subjective experience of being left out or excluded. And this could be true even when social contacts and opportunities are plentiful. And this is a topic that has gotten a lot of attention recently. A number of public health officials are calling loneliness a health epidemic. Loneliness is reportedly so prevalent in the United Kingdom that Parliament has even appointed a minister for loneliness to address this issue. And they actually recently launched a social prescribing program whereby providers can actually prescribe social activities to their patients. And all of this matters a great deal because loneliness has actually been shown to be a key predictor of mortality, even proportional to traditional clinical risk factors like smoking. So some have even estimated that being lonely is comparable to smoking about 15 cigarettes per day, which is pretty significant. So while there are a number of narratives and stories that highlight a link between violence and isolation, very few studies have quantified these associations, and none have actually used a broad subset of social isolation measures. So to do this, we conducted hour-long in-person surveys with over 500 adults from 2 epicenters of violent crime in Chicago. The surveys included an in-depth social network assessment that included social network characteristics, meaning the size or frequency of contact with network confidants, living arrangements like living alone or living with family, social participation in community-based activities like religious services or volunteering, perceptions of social support from friends or family, and then finally also perceptions of being lonely or feeling alone. And what we found was that exposure to violence was linked to higher social isolation and loneliness. Specifically, we actually saw a reduction in the frequency of contact with network confidants, and these are the people that you confide in and share important things with. We also saw a reduction in perceived social support from friends, and notably, we saw a rather large increase in loneliness. Loneliness was actually twice as high in our sample of older adults living in high crime neighborhoods compared to older adults in the general US population. Actually, 2 out of 3 people that we surveyed reported loneliness some of the time. And when we took a closer look at loneliness by specific violence types, we actually saw that loneliness increased in a graded fashion by the severity of violence. So we get higher loneliness from indirect exposure to direct exposure to exposure with PTSD. And you can actually see at the bottom of the figure that we saw over 3 times higher odds of loneliness in those screening positive for PTSD. So there is an incredibly strong linkage between trauma and loneliness. But what I actually found particularly interesting was that even with indirect exposure, we see almost 2 times higher odds of loneliness. And indirect exposure means experiencing violence as a witness or a close friend or family member. So what that tells me is that violence can have these rippling or reverberating effects, not just on the individuals who are directly targeted and who are traumatized by these events, but on the broader community as well. So that's all I have for right now, but I'm looking forward to a lively discussion about these findings shortly.
So I'd like to start off by thanking the entire team at Health Affairs for just creating space for us to have such timely and important dialogues. So over the past year of my own medical education at the University of Chicago, I've watched as our institution developed into a level 1 trauma center, the first on Chicago's South Side in almost 30 years. And as I began to become more involved in patient care and community outreach, I constantly hear individuals served by our institution expressing concern and fear about staying safe and alert as they navigate through our shared environments on the South Side. And this is all really a testament to the public discourse surrounding neighborhood violence. So this is acts of interpersonal violence that take place in public settings. And neighborhood violence can further be classified as community violence, which takes place between civilians, or police violence, which takes place between civilians and members of law enforcement. We've long known that violent crime is a leading cause of death for young people of color, and we hear cities like Chicago, St. Louis, and Memphis described as war zones. So we draw comparisons to the traumatic effects of violence that we see and hear about in our active duty troops. But more recently, particular attention has been given to police-involved shootings of Black civilians where lives are lost. One story that stays with me, though, is that of Erica Garner. So 3 years after her father Eric was killed in an altercation with NYPD officers, Erica suffered a heart attack and died at the age of 27. And I wonder, how did community violence and police violence affect the health of Erica and of so many other individuals who are affected without being direct victims? One possible answer to that question lies in the concept of hypervigilance, which is a state of heightened awareness and arousal that individuals can experience chronically, even when the immediate risk of danger is low. So hypervigilance has been linked to physiologic stress that increases one's risk of heart attack and strokes, as well as impaired memory and poor sleep in veteran populations. But very little work has been done to characterize hypervigilance in other high-risk communities. Our study aimed to do just that. Our primary objective was to examine exposure to various types of neighborhood violence and their associations with hypervigilance. As a secondary aim, we were interested in looking at the relationship between hypervigilance and objective measures of physical health, namely BMI and blood pressure. And we were particularly interested in blood pressure as an outcome due to its status as a major risk factor for heart attack, other cardiovascular complications, stroke, kidney failure, chronic diseases we see commonly in Black adult populations. So to accomplish all this, we created an hour-long in-person survey. Dr. Tung told you a little bit about this. It was adapted using all validated measures, and we recruited a sample of 504 predominantly Black adults from 2 epicenters of violent crime on the south side of Chicago and the west side. So community violence was defined as muggings or attacks that took place in public between civilians, and participants could be exposed not only as a direct victim, but also by witnessing these acts of violence or having a close friend or a family member who had been harmed. The same criteria for exposure, both direct and indirect, were used for police violence, which was defined as any violent altercation between a civilian and a member of law enforcement. And lastly, participants were asked if they had ever been involved in a police stop, which escalated to the point they felt their life was seriously threatened or in danger, which would qualify the stop as a lifetime traumatic event based on DSM-5 validated criteria. Hypervigilance scores were assigned based on the brief hypervigilance scale. Again, this is a validated measure of hypervigilance in non-military veteran samples. It asks about daily watchfulness, emergency planning, scanning surroundings while in public, and chronic fear. And lastly, our objective health measures, BMI and blood pressure, were extracted from participants' electronic health records. Now, moving on to our results. We found that 60% of all participants had been exposed to community violence. Again, that's directly as the victim, as a witness, as a close friend or family member of someone who'd been affected. And when looking at the association between the type of neighborhood violence and hypervigilance level on a 100-point scale, we see that exposure to community violence is associated with almost 6 more points on the hypervigilance scale. Now, the overall rate of exposure to police violence, both direct and indirect, was about half of that of community violence, so about 30% of participants. But police violence was associated with almost double the increase in hypervigilance, so 10 points out of 100. And about 10% of our participants had been exposed to those traumatic police stops where they felt their life was in danger, which was associated with 20 more points on the hypervigilance scale. This was the highest score we saw for any of our analysis subgroups. For our secondary outcome, we found that hypervigilance level in the highest quartile of our sample was associated with 9 millimeters of mercury higher systolic blood pressure. This is a major risk factor for many poor health outcomes, and in fact, studies have shown that for adults aged 40 to 89, an increase in systolic blood pressure of 10 millimeters of mercury is associated with almost 50% greater risk of death from heart disease or stroke. So what can we take away from these findings? Stories like Erica Garner's show us that we must keep addressing the impact of neighborhood violence not only on its direct victims, but on the communities that surround them. We see that there's a state of chronic stress associated with exposure to neighborhood violence, and that violent exposures with law enforcement cause individuals to become especially hypervigilant. Heart disease is the leading cause of death for Black Americans, and an estimated 40 to 45% of Black adults live with hypertension. So the association between hypervigilance and hypertension deserves priority as a public health and health policy concern. And this presents us all with exciting opportunities to create new policies that work towards healthier communities and against neighborhood violence. So for example, our team is exploring best practices for neighborhood violence exposure screening in healthcare settings. And it's imperative that we as healthcare professionals create spaces to discuss these issues and their health effects with those we care for. One of the most exciting aspects of a trauma-informed healthcare approach is the fact that it's interdisciplinary in nature. So we see medical professionals, social workers, community members, members of our legal system working together to create policy and mend historically violent relationships. We see a lot of this happening in community policing initiatives. So we can have town halls with law enforcement and even police youth baseball leagues, which is a new tradition that's come up on the South Side. So I'll leave you with one of my favorite murals from young artists on the South Side that reminds us all that the onus is not on any one group to stop neighborhood violence or its associated hypervigilance, but it's a goal we can all work toward. Thank you.
Morning. I do not have data to present, and in some ways, by the end of this 7 minutes, you may view what you've just heard as a paid political announcement, or a public service announcement would be better. I have had the honor to have a little paper that I wrote on ending gaze aversion, accepted by Health Affairs, and I'm going to present it to you this morning. Just by way of background, I've been in pediatrics for 51 years, and over that 51 years have watched the field of abuse and neglect and violence sort of develop, but not as well as all of the children, most of the children I cared for 50 years ago have developed. But we have not really addressed abuse and neglect the way we should, in my view. Let me clarify what gaze aversion is. Gaze aversion is a phrase that a British psychiatrist, Kid Ounstead, used to describe the behavior of autistic children first, and then later, as he and his colleague Henry Kemp began to talk about child abuse and neglect in the 60s and 70s, used it to talk about the gaze aversion toward the problem of abuse and neglect. It can be deliberate or inadvertent. People desperately hope that whatever they're seeing won't happen. And as I pointed out in the article I wrote, Henry Kemp experienced gaze aversion when he first presented the paper, The Battered Child Syndrome, which is maybe the most widely cited paper in our field. 1,000 pediatricians left his presentation at the Academy of Pediatrics without saying a word and without asking a question. It was not a topic that anyone wanted to deal with. For the last 50 years, child abuse and neglect has been dealt with primarily as a social issue. That's because there were no physicians interested in doing the work in the 60s. And when Henry and his colleagues looked at how are we going to help children and families, the departments of social services, child welfare workers, were available. And in fact, in the 60s and early 70s, they were actually helpful and approached families in a way that did very well. So that many of the families did well. 80% or more would stop the abuse with interventions. But with the recognition of sexual abuse in the re-recognition, really, of sexual abuse in the late 70s, helping child welfare's helping evaporated and was replaced by mostly investigation. I was here in Washington back in 1990 with a group called the U.S. Advisory Board on Child Abuse and Neglect. We called abuse an emergency, and it was one of the many emergencies that was never really responded to. In 2019, and then as Alan mentioned, from 90 until 2015, I wound up in the dean's office at Colorado in a bit of a cul-de-sac away from the field of abuse. And I finally came back to work in 2015, and not much had really changed. NIH has really neglected this particular area. It too is viewed as a social issue, as perhaps violence and many of the things we've heard here are done. One of the things that you notice when you're in medicine for 50 years is that over the last 50 years, we've had an enormous growth in research and an enormous effort to improve the lives of children and adults, disease by disease. This is a list from the National Health Council of some of the 501c3 not-for-profit foundations that have raised money for research and, more than that, advocated for Congress to provide more funds for research for all of these particular diseases. What's been interesting to me as I came back was that if you look at these in red, these are foundations whose disease is related to child abuse and neglect, but they've never funded any studies that had anything to do with the impact of abuse and neglect. Everyone talks about the impact of abuse on suicide, on depression, on obesity and eating disorders, and even violent behavior. But you can't find, if you want to do research in the area, resources to do that. And so there's gaze aversion not only among people who don't want to see the problem, but there's gaze aversion by institutions that don't want to deal with the problem. And none of these, in their 20 to 30 years of funding, have supported the relationship of that problem to abuse and neglect. And I suspect, I know, not all suicide is because someone has been abused and neglected, but some is. And not all alcoholism that isn't treatable is related to abuse and neglect, but some is. So we actually started, how much time have I got? 20 seconds, not much. Perhaps I can come back. I've got a 1 minute and 40-second tape that I'd like to show. And if maybe I'll just do it. I'll pretend I'm a politician. We're trying to get abuse and neglect to be thought of as a public health issue. Health, public health, and mental health. So we started this particular foundation. There has never been a foundation to raise money for research, training, prevention, and advocacy for abuse. These are our goals. You can see it on the website, and I'm just going to start this and hope we have sound. And if we don't have sound, we should go back and maybe do this at another time. Okay, why don't we stop and we'll run this at the break. I don't want to do that. And so much for your paid political announcement. Talk to you later.
Good morning. First, I want to thank Health Affairs for including our work in this briefing today and the special issue. I'm going to be talking about some work that we've been doing funded by the Robert Wood Johnson Foundation to really build a cross-sector intervention to address community violence experienced by African American youth. I want to acknowledge my co-authors, Jeanette Berkeley-Patton, Caitlin Piper, Paige O'Connor, Tiffany Renfro, and Kelsey Christensen, and also our Community Action Board, which is comprised of community and stakeholders and youth who are guiding our research at every step. Oh, it looks like these might be older slides, so I'll just talk first. Okay, so first of all, just to give a little context for our study. So we've been talking a lot today about violence and how it's related to numerous negative health outcomes. And we know that African American youth are disproportionately exposed to community violence. So they have higher rates of community violence exposure, as well as severe forms like violent related injuries and homicides, which is a leading cause of death for these youth. Despite that, rarely have African American youth been engaged in really understanding their perceptions of the issue and what strategies we should be implementing to address community violence. So we took the approach that it's critical to partner with African American youth to design solutions in order for our interventions to really be responsive to their needs and build on their assets and strengths. So our aims, we wanted to start with a qualitative study because we really wanted to understand, gain better understanding of some of those nuanced issues related to response to community violence, and again, make sure that our interventions were really responding to their lived experiences. We conducted 5 focus groups in Kansas City, Missouri, with 39 African American youth who had experiences of community violence. The average age of our participants was 16. And we recruited for community violence exposure, but what we found is that youth in our study had an average adverse childhood experience score of 6. And what that means is that in addition to community violence, they were exposed to numerous other traumas and adversities. So in terms of our themes, where we are, during our focus group discussions, there were several things that came up repeatedly, and so those are our themes that we're really focused on. One was that participants consistently expressed the view that the responses of multiple sectors, and we were focused on law enforcement, schools, healthcare, and the faith sector primarily, were not responsive to their needs, particularly around community violence. In terms of law enforcement, one youth shared, at first, police don't even be there on time. A little boy died because the police canceled or hung up the phone, like they don't get there early enough. Participants also described school responses to violence as limited and often not responsive to the concerns brought forward by youth. They talked about this could be due to school personnel not really understanding the complexity of violence exposure and the consequences. For example, one youth shared, they have all these signs around school, no bullying, no bullying. We telling y'all these kids, some of these kids are suicidal, and you all doing nothing about it. Finally, youth described how a lack of resources within their schools and communities resulted in difficulties with coping. One youth shared, we really don't have no places that can help. It's always like somebody that's gonna die at the beginning of the school year. Everybody really ain't gonna know how to cope about it. So overall, this theme highlights the general consensus among our participants that a more proactive response was needed from adults in multiple sectors to respond to youth after community violence exposure. Our second major theme centered around youth's experiences of racial discrimination. We heard frequently in our focus group discussions different examples of how the impact of racial discrimination really chips at youth resilience over time, particularly as they're trying to cope with the experience of community violence. Youth spoke specifically about their exposure to the trauma of police violence. There's not a law that says it's okay to kill a black man in a car, but we see all these white cops killing black men, and it's okay. Participants also explained how stereotypes of black youth resulted in experiences of them being profiled and misjudged. One youth described this in relation to being in the community, stating, and that kind of irritates me when I want to go somewhere and the police is just all up on me, like trying to see what I'm doing. I just came to chill and have a good time like everybody else is doing, and I'm the one that's getting stopped, and I'm the one that's getting questioned, and I don't even have nothing to do with it. Another youth described a similar experience related to the school setting. So the white principal, she took my backpack and she went through it. For what? I don't know. I was the only black kid in class that day, and so she looked in my backpack. Participants expressed that these experiences were frequent and painful and reinforced a feeling among many African American youth that adults don't understand them or care about them. So participants clearly outlined recommendations to address these barriers to their health and well-being. They recommended several different actions, starting with really emphasizing the importance of mitigating racism and discrimination across sectors. So they really saw this as an issue that needed to be addressed in each of the sectors we were focused on. They also expressed a need for more accessible mental health resources throughout the community and emphasized integrating these resources into important community institutions like schools and churches. Ultimately, safety was a top priority for youth in our study, and participants wanted greater investment in neighborhood and community infrastructures so they could feel safe and have safe places to heal from their exposure to community violence, as well as have safe spaces to interact with other members of their community. And then one of our more nuanced findings of our study was that while youth expressed distrust due to police profiling and violence, they also recognized the important role of police in promoting community safety and expressed interest in building relationships and trust with police. Participants described how greater transparency and accountability would be a foundation for this trust. So in conclusion, African American youth exposed to community violence in our study are asking for support. They want support to promote their health and well-being after community violence exposure, and for this to be a focus of our efforts. They've outlined a clear action plan that includes policy and practice implications and really requires cross-sector collaboration. I think this quote by one of our youth participants really sums that up nicely. We all know that violence and racism and colorism is happening. But if something was actually put into plan, like for people to come together, we actually need people who are motivated to try and fix it. Thank you.
Is this like a pause? Can I, oh, just, hold on. Entertain.
You want to play the video? There it works.
So, you guys are looking a little sleepy this morning. I've been a teacher for a long time, and I've never been able to get a classroom this quiet. So I can tell you, should I start?
If you're comfortable, it looks like we're moving it along.
It's okay, I can tell you. Or you could read the paper. So my name's Bernadette Hohl. I'm an assistant professor at Rutgers. I will forget all of my collaborators on this project, so I will need the slides for that. But I'm here to talk with you about a collection of work that's been ongoing with colleagues across the country, looking at place-based interventions to reduce violence. Where else can I go with that? So the first slide basically says that violence is a public health issue that we need to address. And I think that our first panel and the whole entire room understands that and really needs no explanation. But what we also know is that there are different ways to address issues of violence that go all the way from the individual up to the policy level. And if you're familiar with the health pyramid, when we address things at the bottom of the pyramid, the social determinants that we were talking about, the changes in physical and social environments, we have the potential to create greater population-wide impacts on our outcomes. And so what our research group has really tried to do is take more of the approach to address both the social determinants but also the environmental risk factors that are related to violent outcomes. Oh, here I am. Let me see where I am. So these are all the great people that I work with, and including the funding that has helped to support it. Most of these folks are the PIs and pretty much the leaders in this field that I'm presenting. So what really the take-home message is that we tried to present using examples from our work, the empirical support for place-based interventions, and we use the example of interventions that remediate vacant land and housing. And some of you may be thinking, what the heck is that? So here we go. The examples that we give are from cities like Flint, Michigan, and Philadelphia, New Orleans, and Youngstown, Ohio. There are many others. Some of you may come from these cities. They have cities that have a similar history in that they had a significant period of growth, expansion, success, coincided generally with the industrial work that was that these cities had going on within them, and then afterwards a significant period of decline in that there was an outmigration. It was tied to a lot of indicators of structural racism. It embedded vulnerable populations in high-risk neighborhoods with regard to violence, but also in the context of extreme poverty and other social indicators that are really driving a lot of these negative and poor health outcomes that we've talked about. One indicator of those environments that if you talk with residents, they will immediately identify that's related to violence. But our research also backs up are these physical environment characteristics like vacant lots. So vacant lots, those cities have an exorbitant amount of vacant lots. And you walk down the street and there may be a house, there may be 2 houses, but the rest of them where houses were are no longer there. So what happens is that there's no ownership of those homes, they fall into disarray, they create fear, and they actually create unsafe environments for the residents who live there. So this is just one of many quotes that we had from a resident of Philadelphia that explains the association between these vacant spaces and violent outcomes. And there's research to back up that these places are, in fact, crime attractors, similarly to places like abandoned buildings. Time. Okay, so theoretically, how do we think that these are generating crime and generating fear? We have this thing called disorder, essentially unkept places, vacant spaces, trash, graffiti, other indicators of disorder. That creates a sense of fear and withdrawal that you actually heard many people are already speaking to: social isolation. Otherwise, they can't let their kids go outside. They don't want to go outside because they feel as though it's an unsafe environment, and in fact, there are violent activities that are occurring in the neighborhoods around these spaces. We know that because we all live in communities, that when there's less people outside and less folks that are out there and able to see what's going on, there's less likelihood that grandmom on the corner is going to call out any poor behavior or let you know. It breaks down the social cohesion. The indicators are, though, that as that happens, it actually contributes to more serious crime, and that signals to folks outside of the community that those are places that are not being watched or monitored, and that essentially, theoretically, is how it would escalate crime. And we believe that theoretically believe that it's a cyclical issue. So what are the interventions that I'm talking about? The idea is if we can break the cycle by addressing the physical disorder, perhaps we can have a reduction in the violent outcomes. How do we do that? With fancy little trees and people. What does that mean? That means that across the country, cities are smart and residents are smart, and they've adopted practices whereby they begin to take these spaces, clean them, and green them. Some of the interventions are very simple in that it's just a cleaning, a grading, a greening, and a little post fence. Other interventions are really up to the local residents to determine how these spaces get stabilized. But essentially, the idea is that they get cleaned and greened. And functionally, we think what happens is that it helps to also rebuild the cohesion among the community residents and then sort of breaking this cycle that I described. What we know is that, and someone alluded to this earlier, we need a rigorous evidence base to be able to support that this should become policy across these places. And in particular, this idea that these are already vulnerable populations, and we need to be able to address them in ways that are going to really make an impact on their quality of life and their health and safety. Based on experimental and quasi-experimental research that we've conducted across those cities that I alluded to earlier, we have been able to demonstrate that as a result of the vacant lot stabilization, and we're also building an evidence base around building remediation, that there is in fact a reduction in assaults, gun assaults, burglaries, violent crimes essentially, residents reporting reduced perceptions of crime and safety concerns, reduced feelings of depression, reduced feelings of stress, Those who participate, because there's variation in how these places are stabilized, there are both a remediation program that engages in professional mowing versus those that are really built from a community engaged process. But those who participate in the greening report that they do feel an increased sense of community and opportunities for others, and that others begin to become more interested in being involved in these types of programs. And residents also report an increased use of outside space for relaxing and socializing. So the idea being that it's beyond just the violence reduction, it's an increase in well-being, it's potentially increasing other health indicators. Nice. I'm almost there. So I end because the idea was that we're building this body of evidence, and we really want to have some policy implications. And the idea is that at the end of the day, there has to be some considerations, because there's great variation across the country in how these programs are being supported, implemented, and their effectiveness. And quite honestly, the idea is really, as researchers we say, more research, but we really need to be attentive to building a strong empirical base if we're going to promote this as a policy recommendation. One of the considerations is acceptability. What we've learned from working across the country is that what works in one place doesn't necessarily work exactly in another place. It has to be acceptable to the community. It also has to be acceptable that we study it in the community. Similarly, we're trying to design studies that look like drug studies when we're doing randomized trials. However, what's at least good about these things is that we've learned ways within the communities to do community trials that are acceptable, in the sense that there's a lot of vacant space available to them, available out there. And so by incorporating these lots into stabilization, and then putting them on a wait list, and those that are a control, similar methodologies that you might use in terms of acceptability for other types of studies. Resources are always an issue. Resources for both the study of these place-based interventions, but obviously the sustainability of the interventions themselves. So creative partnerships have come through to be able to try to look at this, but always with an eye towards, once we started, it needs to be able to have a plan to be continued. And most importantly, the idea that there can potentially be unintended consequences to this type of work. And so policy recommendations really need to be made with an eye towards what is acceptable to the communities and what is not. If we're building a social cohesion or we're creating more acceptable spaces, we don't become to displace those community residents that have been there already, or we don't begin to create environments that disrupt the cohesion of the community themselves. So there I am. All right.
I'm going to ask a few questions directed to each of you sequentially. I will say at the outset that it's rare for us in an issue to have two papers from the same study. So it's a sign of how much of a contribution we thought this one makes. Elizabeth and Nichole, for the work you've done, I'm thinking back to our first panel and my use of the social determinants term, and Brianna sort of saying, well, that sort of has this linearity or direction, one-way time directionality, and that if we're thinking about the effects of anything, but particularly violence, we need to be thinking of it in a more ongoing way. I wonder if the two of you could reflect on the work you did in that vein, in terms of you're looking at a period and people's experience during that period, and then how they're doing after. But implicit in her answer is that we also need to be thinking about the ongoing changes and responses that may arise. And so I just wondered if you could give me a sort of a more holistic picture of what you saw, in addition to the more linear results that arise from your work, if that makes sense.
So in terms of the more holistic picture, I think research-wise, you tend to be a little bit constrained by study design and your ability to actually monitor people over time. Certainly, longitudinal studies are very important and definitely the next step. I think from a clinical perspective, I think a lot of the interventions right now that we're doing in terms of violence intervention and addressing victim service provision for victims of violence, a lot of that is event-based and kind of after, in the immediate after effects. But I think that's why in primary care there's actually a huge opportunity that is currently being missed in terms of we have these longitudinal relationships with patients. We see patients for 5, 10, 15, 20 years. And we really don't address the issue of violence hardly ever. And also to your earlier point about violence not being addressed in the social determinants world, I would say clinically that's very true. I think that there are a bunch of social determinant screeners being released lately. Medicare has one that addresses housing, transportation, food insecurity, and it only addresses intimate partner violence. It doesn't look at any other form of violence. And I actually had a patient once who was wearing a T-shirt that had RIP on it, and it was three RIPs, 3 names, and 3 dates. And I asked her about the T-shirt, and she told me that she had been coming to the clinic for over 20 years, and nobody had ever asked her about that T-shirt before, even though she had worn it many times. So I think that there are just kind of fears and concerns in the clinical world about addressing violence because we feel like we're opening a can of worms. As a provider, I have 20 minutes per patient. You get really concerned that it's going to take up all of your time. But I think that in terms of addressing violence more holistically and long term, the place to do it probably is in those longitudinal continuity of care situations.
Thank you. Nichole?
Kind of going off of that, I think one of the reasons we were so interested in neighborhood violence specifically is the fact that it has to do just as much with actual experience of violence as it does with perceptions of neighborhoods. I actually conducted a lot of the studies, and what I found in talking with the patients, or the surveys, what I found in talking with the patients was that they would say, I've never been involved in this and that, but I know that this neighborhood is dangerous. I know that I can't go outside because of these reasons, and I think that affects the ways in which people interface with the healthcare system, interface with, grocery stores, pharmacies, resources in their neighborhoods, and I think that perceptions of the amount of violence that one could experience on any given day can be just as real for people in limiting their experiences of health.
That's very interesting. Thank you. Dick, your list of organizations showing the absence of any around child abuse and neglect, I didn't notice any around violence in general. And so I wonder if this is gaze aversion, narrowly or broadly. I just wondered if you could reflect on that.
I think it's both. The difficulties I think the violence research folks have had have a lot to do with how this country and some people in this country view guns as a political issue, and we're going to talk more about that later. But I do think that we need the model of having the public view this as a public health issue, and people looking at it as a health issue can help us generate research dollars if we can identify who the advocacy group is. Many of the victims of violence, it seems to me, particularly as we've heard here in cities like Chicago and Philadelphia, aren't likely to form an advocacy group. We think in the area of abuse and neglect that there are millions of adults who've experienced this in childhood, survived it, and done well. who, if they thought of it the way the hemophiliacs think of the National Hemophilia Foundation and cancer survivors and others view it, that's where the advocacy would come to raise the research dollars to the level that they need to be. It's a hypothesis, I suppose. I mean, but nobody's tried it in the last 50 years, so we thought we'd give it a shot.
That's great. Brianna, I wonder if you could give us a sense of sort of the institutional response to the issues that were raised by the people you talked to, which are very much about sort of institutional failure. So what's the engagement mechanism? Is there one? How do we take the next step on work like this?
Yeah, I think that because it's so many different institutions, we're really focused on how do we start to leverage the resources within each and break down some of the silos. So a lot of the sort of lack of response, I think, is because people think the issue's so big and it's someone else's kind of purview to really focus on, especially if you think about, well, maybe law enforcement is going to manage the crime piece, but then who's going to deal with the mental health? And then maybe mental health's going to kind of do that, but they're never going to see those folks that were actually affected, you know, in the community. So a lot of it is really talking to institutions about their strengths and then figuring out where are those gaps that we can start to work together. But that does require a lot of work around policies because these institutions are built to function independently often. So when I was at a children's hospital, we're trying to do a lot of work with law enforcement. There were just issues around confidentiality, and, you know, just these things that are really important parts of our system that really takes a lot of time and commitment to work on. So I think it's bringing people together at the table and then having a long-term view of it.
Thank you. Bernadette, one of the things one hears, and this is not my area of expertise, is that, you know, you sort of fix up the one neighborhood and the crime and the bad people just move to another because levels of crime and drug use are exogenous. And so you're just sort of shifting the problem. I wonder if you could respond to that, educate me, and also talk about how in the communities that you looked at, whether there was a sense of the actual underlying problems declining or moving.
So you're not the first one to wonder about the shift. And because of that, we've tried to incorporate that into our work and make sure that we're testing for displacement. And in fact, most of the work that we've done has shown that it doesn't displace the issue. It actually reduces the crime overall. And so we are definitely careful to look for those things. And then the second part?
Well, if I'm not the only one to ask the question, I guess the question is, in the communities that you studied, was there a sense of success, I suppose?
Well, so what's great about the work that we do is that the communities knew already what it was doing. So we just came in to basically add a layer of the science to support the work that was going on. And so you could hear pretty clearly from community members that in fact, once the places are attended to, that there's opportunity, that they feel safer, but also then there's opportunity to do more and utilize those spaces. And so so in fact, we pretty much make sure that we're checking in frequently and learn quite a bit from our community members that really tell us what to do.
That's great. Okay, we do have some time for your questions. There's a lot of new information in these papers, and we'd love to get can't all be this shy. Gentleman over here, we'll get a microphone to you, and then we'll come to you in a moment.
Good morning. We obviously have a talkative table on this side. My name is Ambrose Lane Jr. I chair the Health Alliance Network, which is a community-based health advocacy group, but I'm also a mayoral appointee to the Commission for Health Equity here in the District of Columbia. And I don't think that you can have a conversation about violence and health without talking about racism. And talking about racism and how it's manifested through social and economic violence that's on all communities, not just communities of color. We're currently mainly focused on mitigation and intervention of violence as opposed to prevention of violence. That's not just here, but that's in most of the conversations that I engage in on violence. It's mainly focused on mitigation and intervention. And on a macro level, just an example that I'll cite is gentrification. Gentrification here in DC. DC has the highest rate of gentrification in the country. And then there is also local political negligence of communities over the course of decades. All of that lends towards communities that experience violence, whether or not that negligence is political in terms of policy, in terms of not, for example, someone mentioned about dilapidated housing and empty spaces. The other piece to that, if you look at it at a more granular level, it manifests in poverty, food insecurity, and hunger. Why hunger is not being mentioned as a piece of that puzzle that lends towards violence, because there are several studies that show the link between hunger and food insecurity and violence. And how I came across that was being in a room with violence interrupters, talking about violence and how those interrupters, in working with people on the street, often relate the story that those people are hungry. So I started doing research and found that out. And then lastly, there are some suggestions. The CDC has always recommended that violence prevention, mitigation, and prevention that's evidence-based be embedded in our school systems. And so can you speak to some prevention pieces and then talk about some of the issues that I just raised?
I think that's a terrific comment, and I'd like to say that not just in school systems, but before that. There'll be 9,000 children born today in the United States. And each of them will be on a path or a trajectory that will take them either in 20 or 30 years to a room like this, or to be in prison or have been a violent offender of some sort. And we have no idea what that trajectory is like, because we look at things cross-sectionally year by year and have never looked back. But if you look backwards, it begins earlier. And I think that intervention in all of the Head Start programs, identifying the children who are emotionally as well as physically and sexually abused and neglected at that early age, and getting them treatment instead of just labeling them, could help a lot. But it's and all of those things. And they have to not be hungry. And they have to not be isolated and left alone. And they need to be supported. But somehow we've never figured out how to do that. And we all study things piece by piece, cross-sectionally.
Yeah, and I would just add, from my experience working in the schools, it really has to be systemic. So absolutely we need to be able to identify kids early and provide them supports. We also have to recognize that these systems are often experiencing a high load of trauma. And concentrated poverty, all of those factors kind of coalesce. And so how are we thinking about providing supports for the whole system? So like if we implement a new violence prevention program, for it to really be sustained, have we worked really closely with the staff, with the principal, with the district, to make sure there's going to be ongoing funding and support? Because that's another thing that I've seen, and especially in Head Starts, is a great program comes in, the funding is gone, and it stops. And people are, that, when you think about that sort of toll, is another issue. So I think absolutely we need to be thinking about prevention and thinking about it really at multiple levels and making sure our resources match, what we're setting out to do.
Come here. Oh.
Hi, my name's Helena Roisman, and I'm a clinical social worker, and I'm the Injury Prevention and Outreach Coordinator at GW Hospital here in Washington, D.C. So what I've noticed, and even in this talk so far, it just seems that we have identified interfaces of the population at need and where we can make an impact, whether it's in schools or in primary care settings or whatever it is. But we don't have the resources and we don't have the training to offer. So a physician is not going to want to address PTSD in a trauma patient at the outpatient clinic if they don't have something to offer that person. So how do we come up with these things to offer? How do we increase the resources for schools, for young children in a pediatric care setting? How do we increase the things to be offered when we have identified the issue? And the other thing I wanted to just ask Ms. Hohl is, in your research, did you look at the reason why the violence went down post this intervention? And I'm curious if looking at the kind of mental health aspects, like the idea of feeling accomplished, or the kind of inner workings that the end result becomes the decrease in violence within the community.
I'd like to take on the first part of that. I can't answer the second. My modest proposal is, since healthcare is now only 18% of the gross domestic product of the United States, that there is money there and a structure there that could actually provide the multidisciplinary teams and setting in the primary care system to actually address the behavioral health and social needs. Now that physicians are finally talking about social determinants of health, we shouldn't be sending children and families off to another agency who will then send them to another agency. And maybe they'll be able to get mental health care, but probably not, because we've got the chronically mentally ill that we're trying to serve in all of those settings and can't. And so we really, I think, need to evolve toward a health-based approach with a system that now has the money to hire all of the behavioral health and social workers necessary to provide one-stop, one-place care for children and families. I answer the question on your.
I would also add, this is probably a bit of a meta answer, but I think that we need pretty dramatic kind of change in the way that we finance healthcare in America. I think that there are a lot of hospitals in the country that are closing in a lot of these regions, maybe that are dealing with a lot of violence or crime, because we kind of end up in this compounding debt scenario whereby hospitals are kind of rewarded or ranked based on their quality, but then they can't make the contracts with Blue Cross Blue Shield because Blue Cross Blue Shield says, oh, your quality is not high enough, so I'm not going to reimburse you at the same rate that I reimburse this other hospital in this nicer area. And then those hospitals are really struggling to survive, and so we've seen a ton of hospital closures in the very communities that we need these resources in. And this kind of continues to happen. And so I think that from a policy side, we're actually going to need pretty dramatic change in the way that happens, because I know that there are clinics on the south side of Chicago with over 50 providers and 1 or 2 social workers.
Do you want to respond?
Sure, I can talk. I can speak to it sort of quickly. Do we look at why it went down? What it suggests is that there's less opportunity. I mean, physically, the environment doesn't allow for certain types of criminal behavior to occur in people's neighborhoods because there's not ability to hide guns or drugs or otherwise. But the social aspect is really a key component that we're trying to hone in on. As I had mentioned, some of these programs are highly community engaged versus others that are community engaged but just in a different way. And there is something to the social aspect of it, in having more folks out on the street and the ownership and the responsibility that it demonstrates. Not that the community folks didn't have that ownership before, but it demonstrates to those people that are coming into these communities and engaging in violent behavior that it can't happen there. So those are two things that we're looking at more closely.
In the back here. It's probably going to be our last before the break.
Hello, my name is Alec Bose. I'm actually a reporter for Northwestern. I wanted to ask a question. I'm not as credentialed as any of the health experts here, but I do think I've experienced something. On October 31st, 2015, my little brother, Joseph Bose, was shot and killed in Norfolk. And I know for myself, I went through really difficult mental issues. And I was 22, my brother was 20. This sort of led me to think about what somebody who is 10 years younger than we are might feel. So I guess specifically for Ms. Woods-Jaeger, if I'm pronouncing your name right, what sort of impacts have you sort of seen from an emotional issue for Black youth who are experiencing this? Because I think that, for adults, we tend to sort of have a certain view of how we deal with trauma and cope. But while I was in Chicago trying to figure this out, it would seem to be, I was having trouble, getting in touch with parents and things like that. So I just was interested what you found in terms of, how they deal and how they cope with this trauma. Thank you.
Yeah, so I think it's complicated because there is a huge emotional toll. And I mean, in terms of symptoms, we see PTSD, depression, anxiety, all of those diagnosable disorders. But there's also this chronic stress. So for the youth that we work with, it's a lot of, I have the trauma, and then I have the ongoing stressors, so I can never resolve that trauma, really. And I don't have the supports, available to me to be able to really go through that healing process. So a lot of suppression happens, and there's sort of this survival mode, get through it, but that is still there. And so that's why for our focus groups and then in some of the community forums that we've been having since, the big push is we need to have a mental health conversation that really focuses on resources and how they're going to get to the community. They also talked about, not in this paper, but in another one, about family, and that we need to think about the family as well. So just like we were talking about, it's not just the person that is acutely impacted, it's the family, it's the community. So we have to broaden our conversation around mental health and not just think about the treatments in a clinic, but think about how are we promoting mental health on a community level. But absolutely, the toll is very heavy. And at the same time, a lot of the youth that we work with are extremely resilient. So they're very motivated and really want to see these changes in their community and are ready to take action on it.
And I'd like to just add to that. First of all, thank you so much for sharing that. I know that must be really difficult to share with us. I think to that point, we see that these effects are lifetime effects, and I think that's why we were so interested in the screening picture of it, because I think a lot of times whenever healthcare screening does happen for violence, it'll be asking questions about, are you yourself being directly attacked or hurt by someone at this time? But I don't think we're doing enough to screen for lifetime exposure to violence and lifetime experiences with violence and how they may be having long-lasting traumatic effects. So I think that your point is a good one, that we should be asking our youth patients, but also our adult patients, about lifetime experiences they've had and how they may be affecting their health.
Okay, as we move into a break, I do want to note that there is a paper, the author could not be here, but I just want you to be aware there is a paper on firearm owners' prior arrests for driving under the influence and subsequent arrest for intimate partner violence. It's a very interesting paper. I won't try to summarize it here. I could have mentioned in the firearms section, but I just want you to, as you look through the issue, to make sure you keep your eyes out for that paper as well, since it wasn't presented this morning. We're going to take a 10-minute break, but beforehand, please join me in thanking our panelists here. Okay, again, I want to acknowledge the California Wellness Foundation, the Blue Shield of California Foundation, the Joyce Foundation, the Annie Casey Foundation for their support in making this issue and event possible. We have two terrific panels ahead. The next one will focus on violence, mental health, and suicide. You'll be hearing from Bernice Pescosolido, Distinguished and Chancellor's Professor of Sociology at Indiana University and founding director of the Indiana Consortium for Mental Health Services Research. Evan Goldstein, doctoral candidate and graduate fellow in the Division of Health Services Management and Policy at Ohio State University College of Public Health, and Catherine Barber, senior researcher at the Harvard T.H. Chan School of Public Health Injury Research Center, who's led the effort to design and test the pilot for the CDC's National Violent Death Reporting System. I'll turn it over first to Bernice. Whoops, we're at the beginning. Well, can you jump us down to, we ended up back at the top. We've got to move it down to that post-break. Come on up, we'll get this right.
We'll find it, right?
It'll come.
It'll show up.
Let them get us there.
Well, welcome back after the break. I wanted to begin by seconding what Brianna said to start us off this morning, which was if we think that we're not affected by violence, then we're wrong, whether that's directly or in terms of the unintended consequences of the level of violence in the United States. So as social scientists, we were particularly concerned. Hello? Okay. I've been silenced. Oh, there we go. Okay. As social scientists, we were particularly concerned with this issue of unintended consequences. And this includes myself and Bianca Monago, who is a newly minted sociology PhD, now a professor at Vanderbilt University, and John Monahan at the University of Virginia Law School, who is one of the most senior experts on issues of mental illness and violence in the United States. And we were concerned with these unintended consequences, and particularly what has the impact been of violence on American culture? What are the implications of these changes? Because the cultural climate itself reverberates and reflects our lifestyles, our life chances, and all aspects of our lives. And in particular, we were curious about how this might reverberate on policy and public decisions. We're interested in how it affects the day-to-day lives of those targeted individuals. And I think, as Elizabeth mentioned, in terms of the woman who was isolated in her own home because she feared violence. So one of the most obvious ways to think about this was to think about the issues surrounding the roots of mass violence in the United States. It's most often discussed in the policy and political spheres. It really centers on two issues. And one of them is guns and gun control, which I will leave to the other experts here in the next panel that you will hear about. But the other issue that comes up all the time is mental illness, and not mental illness in the way that we've talked about it so far, in sort of a caring way and a concern for the people who are victims of violence. But really talking about mental illness as the cause of mass violence, the American trope that people who are engaged in heinous acts must be sick. And we were concerned with its impact on people with mental illness in particular. So I want to take us back to Columbine in April of 1999, when we began to experience this new phenomenon of mass school shootings. This has been a cohort-defining event for American school children, both the millennials and the new centennials. This is what they think about. This is part of their life. They have never known going to school without being concerned about these issues. But I think for the rest of us, it was really a wake-up call about something happening in American society that we were not concerned, that we had not been aware of before that. Because the people who are engaged in these mass shootings are not like the people that we've talked about so far. They tend to be white boys. They tend to live in affluent areas. They're not in the center cities. They're in suburban areas. And so this seemed like a very new phenomenon, and one in which every time there is one of these events, there's a lot of political and policy discussion and debate. In the middle of this, we had begun the U.S. National Stigma Studies, trying to get a sense of how the cultural climate affects what happens with regard to the lives of people with mental illness and mental health policy and the mental health care system in the United States. And we were able to put a module, a 15-minute module, on the General Social Survey, which is the largest and longest running instrument or mechanism to understand Americans' attitudes, beliefs, and behaviors. And what we did on that, with some generous funding from these different organizations, is to create a series of vignettes or cases, which we presented to the American people. And we didn't label these as having mental health problems, because what we wanted to do was understand in part what Americans would recognize, what they wouldn't recognize. But one of the things that we focused on always was this concern for whether or not the people described in these vignettes were seen by Americans as being likely to be violent. We were also interested in their willingness to evoke the law to force treatment. Of course, there are many cases in which involuntary treatment is called for and an important tool in psychiatry's set of things that they can offer, but sometimes, as we know, it's often used as a method of social control of populations that are undervalued or devalued. So what we did was we gave Americans one vignette. They each randomly got one vignette. We had one on daily troubles. This is a person who doesn't meet clinical criteria for anything. Depression, alcohol dependence, and schizophrenia. And what you see there in the bars, the blue bar is 1996, the red bar is 2006, and the black bar is hot off the press is 2018 survey. What we see there is a drift toward more Americans seeing people with mental illness as violent. Now, these results may not be as dramatic as some might think or might expect to see, but societies change slowly, and the fact that we see an increase in the number of people who are stigmatizing people with mental illness is really a problem. It's a problem because there has been more effort directed toward destigmatizing people in the United States in the last 20 years than there has been at any other point in time. And in particular, if we look at the issue of schizophrenia, we see a fairly dramatic rise from the mid 50% of Americans. That's a very high number, 50% of Americans thinking that people with schizophrenia are likely to be violent toward others, and a 10% or greater than 10% increase in 2018. If we turn to the issue of whether or not they believe that coercion is an appropriate use of force to get people into treatment, we see again that there is this drift. There are a few anomalies with regard to alcohol dependence, but again, we see in some cases a very dramatic rise in the percentage of Americans who are willing to use force to get people into treatment. In particular, again, looking at schizophrenia, we see over time, and particularly in 2018, a return to the idea of having hospitals, long-term care hospitals, and forcing people into those. Perhaps even more troubling is the Americans' response to the person who has no clinical diagnosis, a person who's having problems of daily living, or we call them the daily troubles person. And what we've seen is a dramatic jump over the 22 years in the number of Americans who are willing to see people with daily troubles forced into hospitalization because of mental health issues. So in the end, when we think about the federal level in terms of thinking about mass shootings and the public policy response to it, there really has been little action on either front. We haven't had a lot of success in reducing guns, nor in building a mental health system that really matches the prevalence levels of the problems people have in a society that has a great deal of wealth, as somebody mentioned before this. And neither one of them, I think both of them are sort of symbols of easy way. I mean, they're both important, but neither one of them really tackles the underlying roots of why people are engaged in mass violence. It's a very unique phenomenon to think about some of these issues. And thinking about guns will clearly reduce the carnage, but will it stop these people from engaging in this kind of mass violence? And clearly, decades of research has shown that people with mental illness are more likely to be victims of crime rather than perpetrators of crime. And if you took the violence committed by people with serious mental illness out of the American crime rate, you would be left with 96% of the crime rate. And so the price of this lack of political will that we're experiencing in the United States is that we're not getting to the underlying issues of these mass school shootings. And what the price that's paid lands on the people, providers, and families who are challenged and facing mental illness. Now, I want to end on a positive note, saying that there is some good news in the 2018 National Stigma Studies, which I don't have time to talk about here, but this drift toward higher levels of stigma regarding dangerousness and coercion really reinforces the myth of dangerousness, and it's a view that has greater resonance in the United States than has been documented in other societies.
Right. Good morning. Thank you. You can easily find me in the agenda. I'm the one on the panel without the Twitter handle, so I feel like I'm doing a disservice to my fellow millennials, so mea culpa. But I'm also representing my co-authors, Dr. Laura Prater and Tom Wickheiser. Tom is our Labes Professor and Chair of Health Services Management and Policy at Ohio State and is also in attendance, and we are grateful for this opportunity today. So I'll first just briefly introduce the rationale for our study. Most firearm deaths in the United States continue to be suicides. Internationally, we know that the U.S. firearm suicide rate is estimated to be significantly higher than that of the average firearm suicide rate of many other high-income developed countries, even though our total suicide rate, which includes more than just firearm suicides, is not. And with suicide, the method or the how is critically important. Firearms are the leading method of suicide in the United States, and firearms are far more lethal than other methods of suicide. So this can greatly obstruct our healthcare system's ability to intervene when suicide attempts occur and from preventing additional suicide attempts from happening later on. And in public discussions about policy solutions, a key theme or key themes and narratives emerge, one of which goes something to the effect of that mental illness is linked to violence and gun violence, that behavioral health care is well equipped to treat and prevent gun violence, and that we need greater access to behavioral health care services to successfully treat and prevent gun violence. However, it was unclear if broadening access to behavioral health services does significantly reduce gun-related suicide in the United States. So our objective was to evaluate whether states with greater behavioral health treatment capacity, so more treatment professionals in our study, have lower firearm suicide rates compared to states having less treatment capacity. And so we conducted an observational study and ran different statistical models and estimation methods and examined 50 states in the District of Columbia for 2005, 2010, and 2015. And we sought to estimate whether greater behavioral health treatment capacity was independently associated with more or less firearm suicide. Our main outcome variables or dependent variables were the annual age-adjusted total and firearm suicide rates. And our main or key independent variable was the state-level measure of behavioral health workforce, the size of the workforce. So this included the count of clinical professionals like psychiatrists and clinical psychologists and substance use disorder counselors and social workers and other professionals. And we also controlled for state-level differences in things like the unemployment rate, race, gender, educational attainment, and a proxy for firearm availability, things called like state fixed effects and time effects and other variables that might be related to our outcome variable or our explanatory variable. And so our main finding, cutting to the chase here, is that on average, a 10% relative increase in the behavioral health workforce size would be related to or associated with a 1.2% relative reduction in the adjusted firearm suicide rate. And this was a statistically significant association, but it was a modest protective effect against firearm suicide. So our results suggest that more behavioral health treatment capacity or more treatment professionals may only have a small protective effect on firearm suicide. So this led us to discuss other solutions, or that other solutions would be needed if we want to significantly reduce firearm suicide in the United States. And some of the things that we talk about in the paper, some of the proposed ideas are empowering or supporting our primary care medical systems and our healthcare system more broadly to increase screening about firearm safety and storage practices by primary care providers, family medicine practitioners, and other non-mental health care providers, and also increasing conversations about safe gun storage, which can be critically important for gun owners who have families and homes. Also increasing screening for other suicide risk factors, some of the things we talked about earlier. So other things that perhaps the primary care system can help screen for, like previously unrecognized symptoms of mood disorder or exposure to trauma and a history of violence or exposure to intimate partner violence. Third, collectively, physicians have a long history of positively impacting policymaking and public health practice. And so we discuss how policymakers or the broader medical community can influence policymaking, the political discourse, and support research funding through advocacy. And fourth, and related, and last but not least, we discuss the adoption and enactment of evidence-based policy initiatives around firearm safety and control, especially policy solutions that perhaps at the state level are shown to reduce firearm suicide. And as a final point, we also discussed the need to exercise, or for exercising caution when talking about mental illness and gun violence. And so this is a point that Professor Pescosolido makes with much more expertise and authority, but we also discussed this, and it is really important that it is problematic when all of us, if we publicly emphasize a relationship between mental illness and gun violence. And this can stigmatize our community members, our family members, our constituents who are experiencing mental illness, but who would most likely not be violent or never be violent. And this can prevent individuals from seeking care or adhering to care. Yes. And I think I have enough time, so I wanted to say that, so Professor Pescosolido makes a really important point about stigma and public rhetoric, and she notes that public policy stoked by political rhetoric will not improve the lives of Americans. And we, in a similar vein, make this point that public rhetoric about mental illness may be driving the current emphasis on behavioral health care access as a solution to firearm violence, despite evidence perhaps that strongly supporting that rhetoric. Thank you.
Hi, I'm Kathy Barber. I want to thank the Health Affairs staff for this issue and recognize my co-authors, Marissa Henn, David Hemingway, Matt Miller, Deb Israel, John Barrigan, Kim Myers, and Michael Staley. 10 years ago, suicide prevention groups weren't talking about guns. Gun owner groups weren't talking about suicide. At Harvard's Means Matter project, which I direct, we work to break that impasse and to get both groups working together and learning from one another. And the Utah data linkage study is an example of one such effort. Weird. I don't know how that happened. So back in 2014, a Republican representative from Utah gave me a call to ask for ideas about how to bring down the suicide rate there, where half of the suicides are firearms. And he was a Republican. He was kind of expecting that I would be talking about gun control, and he was delighted to learn that I was recommending an approach that we were using in New Hampshire, where instead of vilifying gun owners as part of the problem, we're seeing them as central to the solution. And in that project, we were working with gun shop owners and the New Hampshire Firearms Safety Coalition to promote sort of a friends don't let friends drive drunk approach to keeping voluntary steps to keep guns from a loved one at risk of suicide until they've recovered. And so he introduced legislation, messaging geared to gun owners, funding for creating these materials, and it passed virtually unanimously. And the state mental health agency put together an advisory group to help create the materials, and importantly, the largest gun lobby group in the state was part of that advisory group. That's the Utah Shooting Sports Coalition, the Utah Shooting Sports Council. In the process of developing the materials together, we developed a lot of respect and trust of one another, and the Utah Shooting Sports Council began seeing it squarely as within their mission to prevent suicide. And these are some examples of materials that we created. In 2017, a Democratic legislator introduced legislation to fund a data linkage study on firearm injury and suicide. A proposal like that would have met a swift death in the supermajority Republican State House, but the Utah Shooting Sports Council testified on behalf of this idea, and it passed handily. So we got the funding to do that study. We took 2 years' worth of suicides, linked them to their hospital visits, to their NVDRS data, and the state public safety agency did Brady background checks to see if all of the suicide decedents could have passed a Brady background check for legal firearm possession on their date of death, and checked whether they were a concealed carry permit holder. So I'll just give you a few examples of findings. How many suicide decedents would pass a background check? Well, it turned out it was 9 out of 10. Findings which makes us realize that the task of keeping guns from loved ones at risk of suicide really will fall to family, friends, to voluntary strategies, to changing social norms. For each finding, I'm going to give the state action that resulted. Within 6 months, the legislature had created a $2 million matching fund, public-private matching fund, to establish a social norms campaign, a change in social norms around routine locked firearm storage and storing firearms away from home or otherwise inaccessibly when a household member is at risk for suicide. The largest private donors, Intermountain Healthcare, the Mormon Church, and the Utah Shooting Sports Council. How many men who took their life with a gun had a concealed carry permit. Turns out it was 1 in 4, which is makes you realize, oh, the permitting process is a good place for intervention and education. And so as a result, now, today, suicide prevention and lethal means safety is part of the CFP application process. It's part of the curriculum for the concealed carry classes, and it's part of the renewal system for renewing your permit. And lastly, what % of rural youth's gun suicides are with long guns? 62%. The state now provides cable locks to all the gun shops in the state to accompany all sales of rifles and shotguns. Previously, that was a requirement only for handguns. At that URL, you can find the report with tons more interesting data findings, and in the paper, we discuss what the political change was to build that kind of trust to enable us to do this sort of very sensitive data linkage, and what sort of political changes needed to happen on the ground to lead to these sorts of direct changes. And I would say that this sort of work, where people who are not gun owners and people who are gun owners work together to figure out the solution to the problem of firearm access when people are at risk for suicide. Thank you.
Just ask a couple of quick follow-up questions. Bernice, stigma and the attitudes that you report don't arise in a vacuum. They occur through complex social dynamics. Given the duration of the longitudinal data you have, what other places do you look for correlates or relevant factors that might either explain or help us think about points of intervention when we're thinking about stigma?
When we're thinking about stigma, I think that, the first thing is that there's a book out called Paradigms Lost that really summarizes all the myths about stigma reduction and then proposes some new ways of thinking about it. I'm joining that group tomorrow at UCLA to talk about making college campuses safe and stigma-free zones. I think the other thing is to look at some of the research that is coming out now that compares media messages. Because one thing that we know is that the most consistent correlate of lower stigma is if you know somebody who has a mental health issue, and the people who have the higher levels are people who believe they don't know anybody that has a mental health issue. And what we're seeing is that there's been some improvement, although I think the release of the Joker last week probably gives us a good indication that that continued link between mental illness and violence in the sphere of movies and television and other media is still there.
Thank you. Evan, it's always hard to know when you see an effect how excited or unenthusiastic you should be about it. So you show a 10% increase in provider supply yielding a 1.2% reduction, and then you go into some other policy areas. I wonder if you could give us a sense of scale in those other areas. Where do we see effects that are large enough that would get you more excited?
Sure. So our goal was not to prove that one thing can lead, proving X, a linkage between X and Y, but rather looking at this narrative that mental health and is linked to violence and more behavioral health care is needed to prevent firearms suicide in particular. And what we show is that this effect is statistically significant, so it might be beneficial in some way, but it's rather small. So then we sort of discuss within the context of other policy solutions things that might be able to be done. But one of the problems is a lack of evidence about how beneficial or how productive those other solutions could be, especially when we're talking about policy changes related to highly politicized or political issues like gun safety, gun control, that might be related to lower firearm suicide, but the evidence is sort of mixed. And there's a lot of good evidence that's been published over the past few decades, largely by people probably in this room, that shows that things like the regional availability of firearms and access to firearms in the home are significantly associated with higher firearm suicide. But then, figuring out ways to carefully address access and firearm safety and storage, and how big of an impact that can actually have, and who should actually be communicating these types of issues and advocating for these solutions, whether they're primary care providers or family members or law enforcement officers, that is still sort of to be determined, I think.
Thanks. Kathy, very interesting story out of Utah, and I guess the question is, if you're in another state, where do you start based on the Utah experience?
Where it's helpful to start is with, I think, with thoughtful gun owners and who are legion. And I think people who are not gun owners tend to, and who are more inclined toward a gun control perspective, tend to have stereotypes of gun owners as being extremists. But within any statewide, among firearm instructors within any statewide gun advocacy group, you're going to find thoughtful individuals who really want to listen to the data. And once you begin working together on this issue, what you think of as a controversial issue becomes entirely non-controversial. It's really easy to find common ground once you start listening to each other.
That's great. Thanks. Questions from the audience on these papers? Ray, we'll get a microphone to you.
Good morning, Ray Baxter from Blue Shield of California Foundation. Thank you very much for the papers and to the previous presenters. The question I have that's been going through my mind as I've listened to these and read all the papers is, and it goes back to Alan's question very early on today about when do we think about all forms of violence alike, and when do we need to think about them separately? The question is, do we need to think about suicide as different from violence directed at another? I mean, clearly there are places where these things come together, like reducing access to guns, which increase the lethality of actions. But is the continuum of potential actions, particularly from a prevention standpoint and so forth, the same in thinking about suicide and violence against others, or is it different, or some of both?
I think there are a lot of similarities, especially for male perpetration of both violence and suicide, in terms of having brittle ego boundaries that say only this far and no further. Once this line is crossed, I have an apocalyptic view towards what needs to happen, whether it's my obliteration or yours. I think there's also separating whether you're going towards suicide or homicide. There's an incredible race division. 85% of firearm deaths in the U.S. among white Americans are suicides. Among black Americans, 85% or almost 85% of firearm deaths are homicide. I think underlying a lot of the issues for both suicide and homicide are racism, that often white people have this inflated sense of need for protection and fear of violence that leads to very liberal gun laws and to keeping a gun at the ready unlocked, which is increasing white people's suicide rate and is also increasing theft of guns, which unfortunately then often end up in communities where there really truly is a homicide problem, and guns that start out as every gun starts out as a legal gun, but often when they're used in a homicide have crossed over, often because of theft of those unlocked white-owned guns. So I think racism actually inflates both suicide and homicide.
Yeah, I'd like to add to that that one of the places where these two come together is in a lot of the mass shootings, where the goal is not only as many anonymous deaths as possible, but also suicide by cop or by social control agent. That's where they often end that way, and they know that it's going to end that way. And I think really underneath a lot of this really comes down to the sense of whether or not people feel that they matter, and whether or not their expression of feeling that they don't matter to society or to people around them in any way really motivates a lot of the violence of both kinds. But I think it's really important to understand particular kinds of violence I think it's separate in many ways in terms of thinking about what is it about what's going on in the inner city that is similar and different from what's going on in these suburban high schools. And while I do think that there's a joint thing about whether or not and how people think about whether or not they matter, I'm not sure I want to mix those two.
But I would just add, I think it's also important, your identity, who you are, your race, and where you're from also affects the potential policy solutions that could be out there, or political support or policy support that there could be behind solutions to affecting the issue that affects who you are, whether it's suicide or homicide. And so identity plays a big part in the actual construction of who people are and what solutions would be available in this calculus of who stands to benefit versus who stands to lose in any kind of solution that we propose.
Take one last question right here in the center.
Hi, thank you. My name is Kirsten Stewart. I'm at Futures Without Violence. And you started to touch on it, and I wanted to just ask each of you to elaborate a little bit on the role of gender norms. When we talk about violence, I haven't heard any serious focused discussion on this. Is largely an issue of men, and the role that rigid gender norms play in perpetration of domestic violence, sexual assault, self-directed violence, community violence. And so I'm hoping maybe you could talk a little bit about, as any of your data, looking more at that. I know with suicide, it's largely because of men use guns, which is why the rates are so much higher. And then also, sort of looking again back at root causes, child sexual abuse and exposure to IPV in childhood seem to be really strong predictors, and I haven't heard those addressed as much. So thank you.
I think gender is absolutely critical in this. One of the things that we see in the recent rise in suicide rates among teens in the United States is a lot about girls, and it's a very different pathway to suicide. It's a pathway of perfection and meeting that perfection but not being able to sustain it, which is very different than the cultural, the masculine cultural script of, it's better to burn out than fade away, and the grand masculine exit. So I think gender and gender roles provide people with very different ways of thinking about how to deal with their hurt.
I think my comments made it clear that I think it's a very gendered issue, and that the vast majority of the perpetrators of suicide and homicide are males, and that it is coming from this kind of so much and no more apocalyptic thinking, even within the name of our project at the Harvard Injury Center is Means Matter. But even though means matter, intent also matters within specific suicide methods. The case fatality rate is still higher for males than for females. And I think it's male perpetration is so overwhelmingly a factor that it almost doesn't get mentioned, because it's like kind of goes without saying, but I feel like the race issues and gender issues are central to violence.
Okay, thank you all for these presentations. We'll move to our last panel.
Thank you, Al.
Just going to, we had some attention to firearms in that last one, but this will focus more squarely on that topic. As folks are joining me up here, you'll be hearing from Jason Goldstick, Research Assistant Professor of Emergency Medicine at the University of Michigan, Director of the Statistics and Methods Section of the University of Michigan Injury Prevention Center. From Rebecca Cunningham, Interim Vice President for Research at the University of Michigan, responsible for fostering excellence and integrity of research across all 3 campuses. Rocco Pallin, Research Data Analyst at the UC Davis Violence Prevention Research Program and Director of the What You Can Do Initiative. And Colleen Berry, Fred and Julie Soper Professor and Chair of the Department of Health Policy and Management at the Johns Hopkins Bloomberg School of Public Health. I'll turn it over first to Jason.
Thank you. So this paper here is it's a Data Watch article, which is basically it kicks off this section by talking about descriptive epidemiology of firearm death in the United States over the last 20 years or so. So as you probably know, firearm homicide, suicide, and unintentional death rates are much higher in the United States than they are in other industrialized countries. And this is sort of emphasized by what you see in this figure here, where what's on the y-axis here is the CDC death rates, which are essentially just counting death certificates and over the last 20 years or so. And you can see here that after a pretty stable but still high level from 1999 to 2014, you see an increase in the last 3 years of available data. And the total increase in 2015 through 17 relative to the whole period before that equals about a 14% increase in mortality. And pretty much the purpose of this paper, this descriptive epidemiology, is to describe how this trend is reflected across states and across subpopulations and different mechanisms of death. So looking at the national trends, comparing those 2 time periods, what you see here is, for example, on the right, you see age groups, and in every age group there were increases. The magnitude of that increase sort of varies a bit across age groups. And on the left side, you see race and ethnicity groups and mechanisms. And what you see here is that suicides and homicides both increased. The only demographic group actually here where there was a notable decrease is among Hispanic whites. And you can't really see it because the bar is very thin here, but there was a decrease in unintentional firearm deaths during this time period also. So sort of looking at how this breaks down across different states, this is total firearm mortality here. So what we did was we took the trajectory within each state and we sort of smoothed out the year-to-year variation, created a trajectory for each state, and we looked at the total percent change from 1999 to 2017. And one thing that's notable here is that over half, actually 29 states I think, showed a more than 20% increase across that time period. And only 4 states showed a statistically significant reduction during that time, which were California, New York, Nevada, and Arizona. And only 4 states showed basically a flat trajectory, which indicating no statistically significant change during that time period. I think what we really wanted to look at here, though, is to look at trajectories within each state. And I could not convince Health Affairs to let me put a grid of all 50 states showing an entire trajectory here. I tried, though, and it is in the appendix, though. And so I picked out 4 quintessential trajectories here. And here, Arkansas is a good example because it basically mirrors the national trend, which is basically a flat level followed by an increase. And that growth pattern was seen in 21 out of 50 states. And the next most common one was basically a linear growth pattern shown in Ohio here. And there were some other ones, but I encourage you to look at the at the appendix if you want to see your state. And actually, one thing I think is particularly interesting, and this also I could not include in the main part of the paper, but you can look at subpopulation trends within each state also. And I chose Michigan because we're from the University of Michigan, and it has some interesting trends here, I think. So what you see here, this is colored by changes relative to 1999. So white indicates little change, and red indicates greater increases. So an increasingly red row, for example, the age 55 to 64 row shows basically an increasing trajectory for the entire time period, and blue is the opposite. So you can see here that overall there was an increase in Michigan, which has relatively small magnitude compared to some other states, but the increase in Michigan was about 10% over this entire time period from 1999 to 2017. And you can see that the largest increases in terms of age groups happened among people over 35, and you can see among people 15 to 24 there were actually decreases. And you can also see one thing I think is particularly interesting about this plot is if you look at the homicide row, the second to the top one, there basically is no change during this entire time period in Michigan. So if you look at if you got on to CDC Wonder and looked at the homicide rates in Michigan across this time period, you see that they're basically not changing at all. They're flat around 6 or so per 100,000. But at the same time, you can see that suicide rates are increasing in Michigan pretty substantially, much more than the overall firearm death rates in Michigan. So, I guess I encourage you to look at your state and look at this plot in the appendix as it applies to your state. And I think what I would take away from this in Michigan is that maybe some of the higher leverage points in Michigan to reversing the current trend is to look into the age groups over 35 and to focus perhaps on suicide. Not that you should not focus on homicide, but yeah, and that's about it. And so you can follow up with questions or on Twitter.
This is yours, Jason. Yeah, thanks, Jason. And there is, to reiterate what he said, every single state is in the appendix with that same graph, so you really can see how your state is changing. So I can't thank Health Affairs enough for putting together this full issue and this briefing today and really focusing the attention on violence broadly. And if I go forward here, I'm gonna take us up a notch and think a little bit more big picture here for a minute, but just before I start this, a few sort of big picture thoughts that I've had from the morning listening here. So one, I think the overarching concept when I think about the conversations going on today is just a reminder that it's poorly understood in the public right now that violence is a preventable public health problem. It's seen as a confusing issue that is societal and not addressable, but it follows many of the other common threads that we could identify with infectious disease or cancer or other types of health. It's a preventable health problem, and that's why with preventable health problems we can address them with the models that are being talked about here this morning and decrease the problems that we're seeing in health. It's not that it's too complicated. A couple other big picture things here about the morning are and we're going to talk about firearms here specifically, and firearms are one kind of violence overall. It's important when the difference really being, because there's an entire field of violence, as I just mentioned, is preventable. The lethality, once we get to firearms, is what completely changes the conversation. In terms of what the one thing is that we should be doing as we think about violence as a preventable health problem and firearm injury that we'll be talking about here and what's needed for the field more broadly is to get away from this idea. I was thinking about the 1990s comment, it's the economy, stupid. It's a field. stupid. It's not a question. And when you see all these panels that are up here this morning, this is the entire field that needs to grow. And all of these issues have to rise. And that's why this issue is, I think, really seminal and really important. And then before I start here, my favorite quote from a Surgeon General who would talk about firearms, David Satcher, is, if it's not a health problem, then why are people dying of it? And I think we can never really get away from that. This is a health problem. And so with that, as a health problem, we look to the agencies that fund health problems. And that's what our study looked at here. So we've talked about firearms a lot this morning. Our goal with this study was to try to get at that question. There's been a lot of screaming lately about we need to do more for firearm violence and we need to understand what's going on with the problem. We need to fund research in it. But if we're going to dig down into that, exactly how much funding? What would be a reasonable amount of funding? How could we try to get, I like data, how could we get an objective number out there for what should we be funding this for? And we focused on children and teens specifically. One, because it's the leading cause of death. Firearm death is the leading cause of death among high school students in the country. The second leading cause of death among all of our children after infancy through the age of 18, from 1 to 18. And so I think we can rally behind the idea that for our children, despite what the politics are in the rest of the country, we should be investing more in how we keep them safe through their 18th birthday and how we address this health problem. And so what are we doing for the funding on that? So we took a look at methodology, which is in the paper, and I won't bore you with a lot, but looking at the Federal Reporter Database, at what's been funded essentially over the past decade from 2008 to 2017. We stopped at 2017 because that's the last data that we had. And then we looked at death data from the CDC, so two very objective measures. And tried to get a sense of we know we're not funding this very much, but how much is not very much is the overarching question, and what would be a reasonable investment to put forth solidly to say we care about this as much for our kids as the other things we care about for our kids that are killing them, and so what should we be investing to try to address this problem, this field, to fix this problem. So for motor vehicle crash, motor vehicle crash is the leading cause of death. Firearm injury is the second leading cause of death. Cancer is the third leading cause of death for children 1 to 18. That's why we focused on those. All of these numbers that you see here are deaths for kids 1 to 18 alone. That's why opioid overdose, some of you would expect to be higher, but this is how many kids 1 to 18 die of this. Congenital abnormalities, sepsis, other things that we hear a lot about and are funded very well. There's an entire Institute of Diabetes. Other things that are not so much of a problem anymore, our children actually don't die of tetanus very much anymore. And then we went through and referenced how many research-funded awards have happened over this time period. Different from other studies that have done before, we included NIJ research. We included CDC research, and we included NHTSA research to the extent that it could be applied to motor vehicle crash as well, to really try to fully understand how much we're funding these problems among kids. What we found here, so for motor vehicle crash, again, this is just federal funding, not car agency funding, not car manufacturer funding, not funding that addressed adults. The awards had to specifically, the funded grants had to specifically address kids in it. So what we found is that we're funding on average about $88 million to keep our kids safer in cars over the last 10 years. For cancer, about $335 million in the last 10 years to address the cancer rates, which is the third leading cause of death. And for firearm injury, if I had one giant takeaway here, it's that we haven't tried at all. And so when we think about where we are with this field this morning and how this conversation has gone and how much we still need to know, it's not that the problems are too complex. I will argue heavily they are not more complex than HIV, which is a complicated social issue, right? Not more complex than sepsis, complicated biological issue, or cancer, or motor vehicle crash, which as an injury prevention researcher is really the closest example that we have for firearm injury. It's not more difficult to solve than any of those problems. We just have decided to not try. So I really appreciated the comment this morning on child abuse and how we've averted our eyes. We've just 100% averted our eyes, and we've decided not to try. And while we did that over the past decade alone, 20,000 children died. And those are just the deaths. We talked this morning a lot about the subsequent effects on communities and the long-term traumatic effects of how that affects our entire lifetime. The gentleman who stood up who will have the lifetime effects of having lost his brother. These are just the deaths. So we took a look at that. I'll also note here that we're continuing to fund some things, tetanus, meningitis, that are important areas of research. Certainly, I'm not arguing they should not have that funding, but this is how we prioritize in our country what we're going to invest in for health is how we fund the research. This graph I think you all have on your table and really speaks for itself and just really shows pictorially what I noted before, which is firearm injury is not even anywhere near on the curve. If we put it on the curve, then we would have a lot more solutions because, and I appreciate also Dr. Barber, who was mentioning before, these, the solutions we're gonna have here, the only solutions we hear politicians fighting over right now with firearms are background checks and red flag laws. Those are the ones we hear. They may be important solutions, but a lot of the solutions that we're going to have are going to be local solutions. They're going to be with families. They're going to be with communities. They're in order to find that vast amount of solutions, we're going to have to build this entire research field. There are many other solutions that could be put forth that can't even begin to be argued about and later will be screamed about, I'm sure, as well. But we can't even get to that level because they haven't been developed yet. The field just hasn't been allowed to mature. So who has funded this in the past decade? We also looked at, which wasn't very hard to break down because we only had to go by hand through 32 grants. So that was pretty easy to do. That wasn't even an hour's work for my research assistant. So NICHD in this space, and again, this is among kids and teens, although I have to tell you there's more funding on this for kids and teens than there's really been for anybody else. So although you could say, yes, this isn't for the adult population, there's more for this than there is generally for the field. NICHD has funded 11 awards for the 20,000 children that have died in the past decade. Nichole A 6, NIDA 5. The CDC won for $37,000, thank you very much. NIJ 4. So the results of this, and this isn't the best graph to show it, but the sum of this point being that what happens with science is if you don't develop the awards, then you don't have the publication outputs. And if you go back to this graph here, publications, we don't have data to talk about if we don't have the awards funded at the outset. And so motor vehicle crash, all that money that we invested came up with over 2,000 papers that scientists talked about, journalists wrote about, the American public knew about, and we figured out how to incorporate into our life. For firearms in the entire decade, that was only 540 papers, and they weren't funded very well, and so the data wasn't very rigorous in it. And this is why we don't have a field. Cancer, on the other hand, 50,000 papers. So there's been no serious health threat, and I know I'm out of time and I will finish, I promise. There's been no serious health threat in the past 100 years that the federal government hasn't invested in. And I appreciate dramatically the investment and the local funders and the foundations that helped do this briefing today, as well as who are beginning to build momentum around the country, and that's really important. And that's going to be the groundswell. University of Michigan announced this past week that we also will invest and build this field as an institution. But that being said, if we're going to follow the lead of how this has been successful with any other major health problem, from HIV to opioids to the Ebola crisis, private and foundation investment has been 6% of the total amount needed to be invested, and we have to have a federal investment for this, for a federal problem, for our national public health crisis. In 1965, the outrage that we had with the leading cause of death being car crash at the time led to this massive federal investment. This massive federal investment, which I would argue we're at the same crossing point right now for firearms in the country. At that time, there was outrage in the country. There was carnage on the roads. We developed NHTSA. We funded an entire field with billions of dollars, and we, somewhere along the way, dreamed up airbags and a lot of car safety and a lot of road safety. And that is the path forward for how we're going to build this field here. The result of that federal investment that we made as a country, because we decided this was a priority, was a 76% decrease over the past 50 years in car crash deaths among kids and teens. So if we make an investment in the country now, we could have a 76% decrease in firearm deaths in the next 40 years or 50 years in the country. That's where we need to go. I'm going to end. Yep. Thank you. And that was the end.
Hi, everyone. Thanks to Health Affairs for putting on this event, and I want to thank my co-authors also from the Violence Prevention Research Program. I'm going to talk today about a study that we did on public opinion about healthcare professionals talking with patients about gun safety. I'll first give a little rationale for the study. There are identifiable risk factors for firearm injury, and those are things that healthcare providers can reasonably identify with the patients that they see every day. And sometimes those are the reasons that patients are coming to see their healthcare providers in the first place. But we know that providers don't frequently ask about firearm access, don't assess risk, and don't counsel on gun safety when it's indicated. There are a number of barriers that research has cited, and we also have anecdotal evidence. And among those barriers is that providers don't feel that patients will be receptive to these conversations, and that patients may feel alienated when guns come up in the exam room. So we wanted to learn more about this public opinion, and we fielded the California Safety and Wellbeing Survey in October of last year. And it was a state representative online panel survey with about 2,500 respondents. And we asked questions about exposure to violence, consequences of that exposure, opinions on policies and practices related to firearms, firearm ownership and reasons for ownership, and a number of other topics. And so one of the things we did was look at differences between ownership groups. So we divided respondents based on whether they lived in a home with a gun but were not the owner, owned a gun, or did not live in a home with a gun. And so we look at the results as a total sample and then also divided into these ownership groups. The first question for this section of the survey is, in general, how often is it appropriate for doctors or other health professionals to talk with patients about gun safety? And so you can see from the bar on the left that about 2/3 of respondents said it was either sometimes, usually, or always appropriate for healthcare providers to talk with patients about gun safety. We found that the largest difference between ownership groups, and really the only difference we saw between ownership groups among these questions, was related to this in general question. The 5 bars on the right are the results for the same question, but when a patient has a gun and the patient or someone in the patient's home has a risk factor for firearm injury. So those are things like thoughts of suicide, misuse of alcohol or drugs, dementia or cognitive impairment, and then living with children or teens or living with someone who has dementia or cognitive impairment. And what you can see pretty clearly from the comparison with the bar on the left is that support is a lot higher. Or the public finds these conversations more often appropriate when there is specific risk. And so I'm not going to show the results for the breakdown in ownership groups, but there were a few differences between the groups of owners. So owners varied much, or owners were very similar in their responses to these questions compared with the non-owning groups. So the next question we asked was, in general, when a doctor learns that their patient has a gun and is thinking of using it to hurt themselves or someone else, so that's acute risk for firearm injury, how often is it appropriate for the doctor to take a number of 5 interventions? The first was counsel a patient not to hurt anyone. That's the bar on the far left. And we include that sort of as a baseline measure. That seems like something that would be generally appropriate. But you can see that the other interventions, which include things like counseling the patient on temporary transfer of the firearm for the duration of the crisis, informing the patient's family or informing the police or informing a mental health professional. Support for those 4 interventions were fairly similar to the original, to the baseline measure, and all were above 80%. We also did not see differences between ownership groups here. So owners were, very many owners were supportive, large proportions of owners were supportive of these conversations in the presence of acute risk and when a patient had a gun. And I'll also add in, although I'm not going to show a graphic, that we looked at the number of people who said it was never appropriate to have these conversations in general, but their responses to the questions in specific risk scenarios and when there was acute risk. And we found that more than 60% of those respondents in those cases said that these conversations were at least sometimes appropriate. So this signifies that there is a component, and it's important that there is risk and that providers may have, patients may be most receptive to these conversations when providers approach this from a context of risk. And this finding aligns with the recommendation that providers use a risk-based approach to counseling on firearm safety rather than a universal approach. And we also found that intervention is appropriate. Things like temporary transfer haven't been asked about for public opinion in the past, and so we found that a large proportion of owners were supportive of the idea of temporary transfer of firearms when there's acute risk, and that may be a notable finding. We suggest, though, that providers are aware of different state and local statutes that might apply to these sorts of transfers and other laws related to firearms and who can temporarily hold them in these kinds of situations. So finally, we suggest that there's a collaborative approach to developing provider education about assessment for risk and gun safety, because there are many other barriers to providers asking about firearm access when it's relevant and counseling on safe firearm practices. And that includes that there overall isn't a lot of education on firearms for healthcare providers and who's at risk and how to talk with patients about gun safety. So to talk a little bit back to Dr. Cunningham's points about funding, the state of California has just appropriated funding to do this kind of work and develop an educational program for healthcare providers that'll be statewide, and we hope that may become a model for the nation.
Thank you.
Good afternoon. I'm pleased to have the opportunity to present findings from our study on trends in public opinion on U.S. gun laws. I want to...
Right, there you go.
Perfect. Gratefully acknowledge my co-authors on this work, and in light of our prior discussion, gratefully thank our funder, the Smart Family Foundation, for funding our 2019 survey. Our paper reports on findings from the Johns Hopkins National Survey on Gun Policy. We've been tracking public opinion at the national level on dozens of policies aimed at reducing gun violence every 2 years during the month of January since 2013. This paper reports on the 2019 study relative to prior years. 2019 is our fourth wave. As in prior years, in 2019, we find widespread agreement among gun owners and non-gun owners and across political party affiliations for many policies aimed at reducing gun violence in America, including purchaser licensing, 77%, universal background checks, 88%, gun prohibitions on people subject to temporary domestic violence restraining orders, 81%, requiring greater accountability for gun dealers unable to account for guns, 83%, and two key elements of extreme risk protection orders, also known as red flag laws, authorizing law enforcement to temporarily remove guns from individuals determined to pose an immediate risk to self or others, 76%, and the other component, allowing family members to ask a court to temporarily remove guns from a relative believed to be at risk, 80%. For all of the policies I just mentioned, plus a bunch more, support was high among both gun owners and non-gun owners. However, there are some policies where we see in 2019 and have seen over time bigger support gaps. For example, we see a 30 percentage point gap between gun owners and non-gun owners for banning the sale of assault weapons, 64% support overall, but 42% among gun owners versus 72% among non-gun owners, and a 32 percentage point gap between gun owners and non-gun owners for banning the sale of large capacity magazines, 61% support overall, but 38% support among gun owners and 70% among non-gun owners. As this figure shows, support levels in 2019 were quite similar to prior years. To the extent that we've seen changes over time, these changes are in the direction of growth in support for policies to reduce gun violence. So, for example, between 2015 and 2019, public support increased significantly for policies requiring purchaser licensing, universal background checks, prohibitions for individuals with multiple DUIs owning guns, better information sharing with police relative to problematic gun dealers, extreme risk protection orders, mandatory minimums for knowingly selling guns to someone prohibited for having a gun, and safe storage policies. Our 2019 survey examined for the first time public support for concealed carry policies. We found high public support for requiring safety training when applying for a concealed carry license overall, 81% support, and high support among both gun owners, 73%, and non-gun owners, 83%. But for all other measures related to concealed carry, we see big differences between gun owners and non-gun owners. For example, 55% of gun owners versus 29% of non-gun owners supported allowing concealed carry on college and university campuses. Likewise, 47% of gun owners versus 25% of non-gun owners supported those who are licensed to carry a concealed gun on school grounds for kindergarten through 12th grade. The survey also examined for the first time a number of new gun policies in 2019, including prohibiting a person from making or carrying a gun without a serial number, such as a 3D gun, 75% support for that prohibition, and requiring owners of semi-automatic rifles to be at least 21 years of age, 73% support. Finally, with 4 waves of data and very little variation in public support over time, we now have the ability to combine survey waves to examine geographic variation in support by state. We look here at 4 policies: assault weapon bans, universal background checks, purchaser licensing, and safe gun storage. And we report support for 39 of the 50 states with large enough state-level samples to be meaningful. This is important because national averages may obscure important state or regional differences in policy support. For universal background checks, we don't see this. There's uniform and high support for universal background checks. 3/4 or more of respondents in all states support this policy. We see a bit more state-level variation for purchaser licensing. In 23 states, you can see, it's hard to see here, but hopefully you can see in California, along the Eastern Seaboard, and in the Midwest, over 75% of respondents supported purchaser licensing. But it's important to note that the majority, that is over 50% in the rest of the 39 states we looked at, supported purchaser licensing policy. For assault weapon bans, 50% or more of the public supports an assault weapon ban in 38 of the 39 states, with the highest support levels, you can see here, in New Jersey and New York, and less than 50% support in one state, that's Idaho. Following the most recent series of mass shootings, gun policy has emerged as a focus in the 2020 election. For policymakers at the federal, state, and local level interested in options for reducing gun violence in America, the findings from our survey suggest that they have many different types of policies to choose from that have high levels of support among Americans overall, but importantly, among both gun owners and non-gun owners. Thank you.
I want to start with two quick comments. One is there's also a piece in the journal by Garen Wintemute at UC Davis. He was our issue advisor on improving background checks. He unfortunately couldn't be here today, but if you're looking for more on that topic, you'll see it in the journal. I do want to say I'm a bit daunted in knowing how to ask the questions here. Much of this is about political will, and I don't mind you all talking about it, but I'm not sure it's our core competency. So I'm going to try to snake a little bit around that by asking two somewhat more health policy technical kinds of questions. If you want to bring up political will, that's on you. So the first is we do have, particularly with the last paper, but it shows up in other presentations as well, there are a set of policies that have majority support or majority support amongst various subsets of the population. So my first question is just setting aside political will, if those kinds of, how much do we know about how much of an effect those kinds of policies would have on the problem that we're studying here? Why don't I pause there before I ask my second question? So if overcoming resistance to majority support wasn't a barrier, how far would we have come in addressing the problems that we have? Who's going to take me up on it? Sure.
I think one important thing to say in light of the presentation we heard earlier about the lack of funding in this area is that does not mean we don't know what to do. There is in fact quite a bit of important research on the effects of policies that points us in important directions for which policies can have the biggest impacts in terms of reducing gun violence. And for some of the newer policies, emerging research that suggests the promise of that research. You know, we look at almost 30 policies, so we don't have the time to go through all of them, but, you know, I would start out by saying licensing laws are incredibly important and have a strong evidence base behind them. And one policy area that is gaining popularity, over 15 states have passed these gun violence restraining orders over the last 2 years. This is an area where the evidence that's emerging suggests that these laws can make an important difference. So we have the tools right now to act in ways that involve policy being passed that can materially address the problem of gun violence in America.
Jason?
I'm a statistician, so I'm going to make a comment about data for a second. So I think one significant barrier to answering this question sufficiently is the fact that there isn't very good non-fatal firearm injury data available, and this is a major priority in my opinion. There's also evidence to suggest that the epidemiology of non-fatal firearm injury is different from the epidemiology of fatal firearm injury. So I think to more rigorously evaluate policies, we need to fill that gap first.
Okay, so the corollary, and Colleen, you started on this, is Rebecca, you gave a pretty bold sense of what would be possible if we just made the investments here. I'm trying to understand the relationship between our understanding of the potential effects of existing approaches, the kinds of things we ask people about in the surveys that both Rocco, you and Colleen talked about, and the need to develop new approaches. I mean, airbags didn't sort of, exist, and then they emerged as a new technology. So how much, and part of this is about breaking the log jam, is we keep asking people the same questions, we keep seeing support, but it's rare that we see policy change. Do we need to be looking at other kinds of options, either ones that we know but are understudied or ones that we don't know? Hard to answer that question. Where are we on the path between new approaches and better understanding of existing approaches?
So I'll take that. I want to really reiterate Dr. Barry's point that 100% correctly that just because there hasn't been a lot of funding, it does not mean that there are not things that could be done right now. I think the creativity that we have for those things especially outside of the strict policy realm, are really underdeveloped right now without having more knowledge. So for example, we all know, and there's plenty of evidence to suggest that if the firearms that existed in the country were safely stored and stored away from our kids and teens and away from those that are at higher risk, we would have far less homicide and suicide, far less theft of the guns, as was mentioned eloquently in the last panel. But how do we get families to do that? And that's an empirical research question in and of itself. That's a health behavior question that will require the kind of study that it took to get people to wear seatbelts, which I can remind everybody was very controversial. People did not want to wear seatbelts in this country. People thought that they would burn to death in their car and be trapped, and there was a lot of messaging around that. And a lot of health behavior science research that went into helping families understand how to implement that solution, which we knew would be effective in saving lives. And those are the kinds of questions I think that how to move the needle on those pieces are research questions that could certainly be effective. I think there's also a whole series of design components that are actually not controversial for gun owners, because I also believe this has to be done well with gun-owning families. So for example, one that's been coming up a lot lately is we know that a lot of guns are stolen out of cars. What kind of product design would help us have better gun safe storage within cars, for example? Those are research questions that could be answered, but will require investigation and knowledge and follow-up that are not controversial necessarily, but we don't know how to implement those yet without more of the base being built for the knowledge.
Other thoughts on this? That was really interesting. Okay. Dick, we'll give the microphone to you. It will be there in a moment.
Rebecca, I love the slide with the table of all of the grants, and I just wanted to point out that I think the 11 grants on firearms from NICHD coincided with Fred Rivera's 4 years on the council of NICHD, because prior to that, and we'll see what happens in 4 or 5 years after the grants that were awarded expire, there weren't many. And I know this because I just went off the council, and they doubled the child abuse grants from NICHD from $2 million to $4 million over the past year. And if you included child maltreatment in that table, along with the deaths, which have been stable for the last 40 years, it'll be an interesting.
So I think it's important to have the voices here and the voices that we've had in the past who have been in this field for many years that have been champions of the concepts that violence is an important public health problem. You mentioned one, and there's certainly others that have helped diffuse that, and now conversations like this and panels like this today and issues like this that will have longer lasting will help continue to impart that concept so that we can continue to build the field.
David.
Non-speakers are allowed to ask questions as well. Just want to make sure we all.
I'm happy to yield.
No, please go ahead.
I did this question is primarily aimed at Colleen, but pretty much anyone I think should take a shot at it. What's fascinating to me about the data you're presenting around acceptability of various firearm proposals is the variation in and of itself across the various policies. You might hypothesize that people who just are against having government or getting in front of you with regard to firearms, that there would be very little variation across these. But it was striking to me that universal background checks actually had the strongest support, and that safe storage actually had the weakest support. There's actually probably better evidence around safe storage than there is around universal background checks, and I'm sort of curious if you could speculate a little bit about what drives these differences for support for various measures.
Yeah, so first of all, safe storage has high support overall. Where we see variation is geographic variation. I think that is a really important area where we don't have a lot of good information on support for gun laws, and we need to move aggressively into understanding what the local and state political environment looks like in terms of support, and to understand that support better, because those are the tools that state level and regional policymakers need. They, in some sense, don't care about support at the national level. What they care about is attitudes within their own communities, and that information can give a policymaker interested in moving forward and enacting evidence-based gun policy the confidence they need to know that they have public support that's strong within their region. So that is a real important area of research that we need to move into. And what we did here in the survey was only beginning to scratch the surface at trying to do that. We really don't have sort of the statistical power to look at small area in the way that we need to. So that's one important point. I think what I take away from the results overall, again at the national level, and we didn't know this when we began surveying in 2013, because literally there was no research on public opinion on gun policy. I'm not a gun policy researcher originally, and so when I got into this, I literally couldn't understand why we had so little data on public support for the range of different policies out there to reduce gun violence, and I think this panel reveals part of why that was the case. But once we started surveying to find out that there were such high levels of support across the board and such high levels among gun owners for so many different policies, that really challenges the rhetoric that we hear related to huge levels of discourse in the American public on gun policy issues. That actually is the case for a few policies, but not most policies, and changing that narrative, and as was discussed in the last panel, really focusing on areas like gun safety, where gun owners and non-gun owners can really come together to together push forward policies that will save lives. That, for me, is the exciting part of this research and why we need to extend it and continue it.
Take one here, one in the back, and then we'll probably be wrapping it up. Wait for the microphone, it's on its way.
Ted Goldman, a frequent contributor to Health Affairs, actually. So it just seems like the 600-pound gorilla in the room is the Second Amendment, is guns, is the fetishes of guns. And I'm wondering why there's not a role in behavioral health, in public health, to demythologize guns. Sort of granting your analogy with guns, with road safety, the way we changed the narrative about tobacco and about cigarettes, and the way the film industry changed the narrative about cigarettes over a 50-year period. Why is there not a healthcare, or is there a healthcare role, or how could one change the narrative about guns so that instead of being seen as something cool and sexy and necessary, that you turn them into something that is basically scary and produces death, which is sort of an alternative but an also realistic way to look at them?
The smoking gun, you might say.
So to speak, yeah.
So I'll take that from a little bit of a different angle. So I think a point that was highlighted a moment ago, and a point I hear frequently, is I wasn't a gun policy person. I wasn't a gun epidemiology person. I wasn't a gun any researcher person, because there weren't researchers on this. You know, the best quoted study on this from 2014 that said at that time we only had 45 researchers in the country that really had any clear work in this area. So what happens when you decrease the discourse to that level is there's no conversation about it. So then there's no conversation about the kind of facts that were put forward a moment ago, which is actually, there's far more agreement about a lot of these issues than we hear. And I heard that again in Dr. Barber's talk. When you actually put the groups together, there's often a lot more common ground. And that's the kind of thing that scientists usually uncover in their work. but it requires the scientists doing the work. And that's why this, the infusion of foundation money currently and the beginning of states and universities beginning to invest will increase the number of scientists who are then talking about this, and then will help be able to have that discourse out there. The lack of any knowledge at all, the lack of knowledge that most people are still very surprised when I tell them the leading cause of death among high school kids is guns. Because there hasn't been a lot of conversation about it, because even the most basic data that Dr. Goldstick presented, how many people are dead, is still very not well-known data and very newsworthy, which from an epidemiological standpoint, that's not usually you have to go a lot more subtle than that to get kind of epidemiological data that's newsworthy. So we have to raise up the number of people having informed conversations about it, and that's how you get an understanding about how we can have the understanding of how people can come together on the many ways that they find firearms to be of value in their lives and their homes and not demonize them, at the same time that we understand how we can have safety in our communities again.
Just very briefly, I love this comment. I think it's so important. What we see in the news media is glorification of guns and demonization of mental illness, and the two things together. And so there are lessons to be learned for the public health community, though. It's a huge lift to try to combat those narratives. And I think that there's a role, as there was in the context of public health and tobacco, for research in the context of persuasive communication and how to change the messaging and how to change the frame while respecting the rights of gun owners as well.
Okay, last question back here.
Thank you, and I will try and be brief. Just to circle back to Dr. Berry's previous comments about knowing specifically state public opinion, is there any idea or sense of, for example, how different senators are responsive to their state public opinion and whether that changes depending on where in their election cycle they are?
Yeah, there's a huge research literature in the political science literature on this, and we know that generally speaking, politicians pay attention to political opinion, but they pay more attention to political opinion the closer they get to an election cycle. So definitely this data matters, and the more localized and specific it can be, the better.
Okay, I'm going to make one comment that maybe isn't the right way to end, but I'm just going to say it anyway. It is notable to me how different this conversation is than some of the earlier ones we had, and how devoid much of this discussion around firearms is of issues of race and racism and equity and inequity. And I think one of the cautions we need to keep in mind as we go forward is to not let these be two separate conversations, or we're kind of missing part of the point. And so to me, that goes back to something I said at the outset, and then Ray Baxter extended on, which is this notion of how many different issues are we talking about here. And I guess to me, the way I would close is to note that just as it's quite clear that violence is a category, actually, if I could find someone, was it syndrome? I wrote it down. It was such a great way to think of it, like cancer. We don't have one cancer. We think of it as a collection. Violence is a syndrome that needs to be thought of with some collective perspective, but also in its unique and specific manifestations. I would say that what the second half of our conversation today has made clear is that violence prevention is also a syndrome, that there are certain elements of it that need to be thought of in common, but there are actually very specific targeted interventions that need to be understood one by one, and maybe with additional resources put in this direction, there will be more knowledge, and with more knowledge, there will be more papers, and with more papers, there will be more issues of health affairs devoted to this topic. So please, thank you for sticking with us. It's been a full morning into the early afternoon. Really appreciate your attention and interest. This is recorded. We already know some people are watching it live, but if there are others who you think want to watch it after the fact, it'll be up on our website soon. Again, with thanks to the California Wellness Foundation, the Blue Shield of California Foundation, the Joyce Foundation, the Annie E. Casey Foundation, but also please join me in thanking our final panel today. And with that, we are adjourned.